respiratory. Okay. So with respiratory, one of the things that's going to be a little time consuming is the arterial blood gas, but we can't skip it. So quick anatomy of the respiratory system. There's upper respiratory and there's lower, as you can see in the picture here. We're not going to cover much of the upper respiratory problems. The lower ones like COPD, cystic fibrosis, those we're going to cover because they're more important. Okay, like the common cold, you can read over that. There's nothing for me to really teach concerning that. Okay, so one of the important anatomical landmark is the epiglottis. So in this picture here, you see the epiglottis right above the trachea. Why is this section important? Because we're going to talk about epiglottitis, which is a medical emergency. So every time we swallow, the epiglottis covers the trachea so that your food don't go into your lungs. So it's important for that not to get inflamed. We're going to talk about it again post a bronchoscopy. Okay, so that's why we do that gag reflex and make sure the sensation comes back to the epiglottis so your food don't end up going into your trachea. Okay, so I go over the larynx, the lower bronchial tree. Those are anatomical landmarks. One section I want to point out here that's important for NCLEX is where gas gets exchanged. You exchange gas in the alveoli, okay? Gas does not get exchanged in the primary, secondary, tertiary bronchial tree, only in the alveoli. And you need to have enough surfactant, which we've talked about before with the newborn, in order for your alveoli to work properly. You need to be able to tell when somebody's in respiratory distress. So what are some of the signs, okay, especially for the infant? They'll have what we call nasal flaring, okay? You look at their nails, and the nares, which is the top of their nose, and it flares up, so nasal flaring. They'll have intercostal space thinking in, they take a deep breath, and the intercostal spaces goes in under the xiphoid, the clavicle. So that's a child who's in distress, and when you listen to them, you hear grunting, okay? So here's a nice picture of the alveoli, which is where gas gets exchanged. This is a picture of the exchange taking place, okay? So I want to go over or point out to you how your systems are all connected. So cardio is connected to neuro, is connected to respiratory, and this is a nice analogy of that. So let me show you the connection. So we just finished cardio earlier, right? And here's a picture of the aorta, okay? This is part of the cardiac system. So if you look here, number one says receptors near the respiratory center in the brain, okay, responds to changes in cerebrospinal fluid, hydrogen, caused by an increase in arterial CO2. So when your CO2 level goes up, your brain knows it, and you will automatically hyperventilate, blow that off. Look at number two, receptor cells in the cardiac and aortic body. So the cardiac from the heart has these receptor cells right there that respond when you have a large decrease in O2. So when you're hypo, when you don't have enough oxygen, hypoxemia, when that oxygen in your bloodstream goes down, your heart has these receptors that sense that, and it passes the message on to your brain. So you see how cardio is connected to neuro, is connected to respiratory. So that's what I want to point out to you. Don't ever think of your systems by themselves. They're not, okay? They're interconnected with one another. Here's another picture of that. Okay, so the assessment stuff you can go over. You can look at the skills question. You can listen to the heart sounds on the other website that I showed you. Okay, the different respiratory sounds, you can listen to them on that other website that I showed you. So those are things that you have to just listen to. There's no special anything with them. So now this one is special, ABG. Arterial blood gas is part of your assessment for respiratory problems. Before you can even do an arterial blood gas, you need to do a little test called the Allen's test, okay? So we pull the arterial blood gas for a number of reasons. We're gonna go over why we do that. But before we can do that, you must do the Allen's test. So let's talk about the Allen's test. It's on your NCLEX, whether you're sitting for the RN or the PN, this one's on your NCLEX. So the Allen's test, your purpose of doing this test is to make sure that the artery you're going to use to pull that blood is patent. It's nice, beautiful, open blood flowing through, right? So you're going to occlude, put pressure on both the radial artery and the ulnar artery. Literally put pressure on them until the patient blenches, okay? Their hands get white. And then you're going to let go one at a time. Once you let go, that side is going to flush. It's going to get nice and red. And then you let go of the other side. If it gets nice and red, then that means that artery is patent and you can use it. Okay, you don't ever want to do an arterial blood gas on an arm with dialysis with an atrial ventricular fistula, AV fistula. You don't ever want to do that. You don't ever want to use an arm where there's an infection, inflammation, or mastectomy. You don't want to do that. Okay, so there's specific areas that you can go into. So a number of reasons why we need to pull an arterial blood gas. So now let's go over the values that we're looking for once we pull an arterial blood gas. By the way, as nurses, we don't even do the arterial blood gas, but we get questioned as if we do the arterial blood gas. I wanted to point that out. There are a few content where you get questioned like you do it, but you don't. The external version was one of them when we covered OB. This is another one. Your respiratory therapist does the arterial blood gas, but we get questioned like we do it. So you got to know it. Okay. Now, you know there are some lab values you have to memorize. There's no going around this. You need to memorize your pH balance scale, okay? 7.35 to 7.45. Commit that to memory. You need to memorize your carbon dioxide, your CO2, 35 to 45. You need to memorize your HCO3, 22 to 26. Like, there's no going around it. You've got to memorize these lab values, okay? So please, if you haven't, you're late, okay? So now you do your arterial blood gas. The patient could be respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. Let's talk about that. When is it a respiratory problem? When is it a metabolic problem? Okay, so only the lungs can take care of, handle, balance CO2. Only the lungs. The kidneys cannot do that. So this section, I need you to wake up because you have to process this to understand what's coming up next. Only the lungs can balance CO2. The kidneys cannot do that, okay? So if you're having a abnormal CO2, it is a respiratory problem. Now, only the kidneys, okay, can handle HCO3. The lungs cannot do that. So if you're having an abnormal problem with the HCO3 or bicarbonate, that is a metabolic renal problem. So one more time, abnormal CO2, respiratory. Abnormal HCO3, metabolic. Okay, so make sure you process that because this gets a little bit more and more difficult. Now, when you're figuring out your status of the client, I want you to start using arrows as far as whether the value is up or down. Why? Because we have to complicate this a little bit to where we talk about compensation. And compensation is easier to understand when you're using arrows. So you have a client whose pH is low, below the 7.35 or low, you want to put a down arrow. If you have where it's high, you want to put an up arrow. Same thing for the CO2 or HCO3. The reason is this helps you understand Rome and compensation, which is coming up, okay? So I'm going to come back to Rome in a moment. This goes over each value and why you're monitoring it, the normal value and the purpose. But let's go over a simple arterial blood gas, and then we'll talk about compensation. All right, so normal 7.35 to 7.45 is your therapeutic range for your pH. You memorizing that. 45 to 35 is your normal CO2, your normal therapeutic range. You're memorizing that. HCO3, 22 to 26, you're memorizing that. So there's 3 steps to figuring out what your client is. Step 1 is to look at the pH. If the pH is low, okay, less than 7.35, they're acidotic, acidosis, like you see here in this picture. If it's greater than 7.45, they're alkalitic. So step 1, what is my pH? Is it low? Acidosis. Is it high? Alkalosis. Step 2, what is my CO2? Is it low, abnormal low? Then that's a respiratory problem. Is it abnormal high? Then that's a respiratory problem. If it's abnormal, it's always a respiratory problem because remember I said that earlier. And then number 3, you want to look at your HCO3. If it's normal, then you don't have a metabolic problem. Okay, but if it's your HCO3 that's abnormal, whether it's abnormal low or abnormal high, that's gonna make it a metabolic problem. Okay, so first look at your pH to figure out if you're acidic or alkalitic. Step 2, look at your CO2, is it normal, abnormal? Then look at your HCO3, is it normal, abnormal, to figure out what your patient is, okay? Use your arrows. You're gonna see why in a moment. So let's do this easy question and then we're going to get a little bit more difficult. I'm going to do it with you because of time purpose, okay? So pH is 7.22. So that's low, right? Okay, so that makes this client acidotic, okay? So put a down arrow. I'm gonna show you why in a minute. CO2, normal or abnormal? My range is 35 to 45, so this is abnormal. So abnormal means a respiratory problem. So this client is respiratory acidosis because my HCO3 is normal. You see how simple this is? Okay, so these are the easy versions. We're gonna get more difficult. Here's another easy one. pH is 7.50, so it's high, that makes them alkalosis, okay? And then arrow up. My CO2 is normal because my range is 35 to 45, so this is not a respiratory problem. My HCO3 is abnormal, so that makes it a metabolic problem. So this client is metabolic alkalosis. Now, sometimes you'll get the value and everything is abnormal. Okay, that's because there's compensation. One body system is kicking in to help the other. So you're going to see why we do the arrows. So here you go, pH 7.32. You know that's low and you know that's acidosis, right? PaCO2 32, that's abnormal, okay? So that's abnormal low. Put a down arrow, okay, and put respiratory. HCO3, abnormal, your normal is 22 to 26, but put a down arrow because it's abnormal low, and that's metabolic. Okay, now we need to go to Rome. Okay, I'm gonna come right back, I promise. You need to know and understand Rome in order to do compensation. Rome tells us the pH and the CO2 always do opposite thing. They're never up together, they're never down together. That is the system with the original problem. Whenever you see Rome happening, that is your original problem, okay? Rome tells us metabolic, the pH is always the same as the HCO3. They're up together, they're down together. So when you see that, that is Rome, that is your original problem. So in the example we had earlier, we had down arrow for the pH and we had a down arrow for the CO2. That is not Rome because they're both going down. That is not Rome. That is because your respiratory system is compensating. Your original problem is a metabolic problem. So this client was metabolic acidosis with the respiratory system compensating. And it was partial compensation because your pH was not within range. I know this is complicated, so I'm going to repeat it. In order to figure out compensation, you need to use the arrows. That little mnemonic Rome helps us. Rome tells us the pH and the CO2 do opposite. When you see that, that is your original problem. It would be original respiratory problem. Rome tells us the pH and the HCO3 up together, down together. When you see that, that is your original problem. Like in this example, we had a down arrow for acidosis. Okay, we had a down arrow for the CO2 and we had a down arrow for the HCO3. The one that's doing Rome here is the metabolic. So this patient is metabolic acidosis, partially compensated. Now it gets a little bit more complicated because you're asking, why is it partial compensation and not full? The only difference between a partial compensation and a full compensation is when your pH is within 7.35 to 7.45. So when you have a normal pH, you're fully compensated. Okay, here's an example. So 7.35, that's normal, but it's normal low. So put a down arrow, okay, and put acidosis. CO2, that's 35 to 45, right? That's normal, but it's normal high. Put an up arrow, okay? And then put respiratory. HCO3, 22 to 26, that's high, Okay, CO2 was high, and HCO3 is high. That's high. So put an up arrow, metabolic. So we have down arrow, okay, acidotic patient. We have up arrow for the respiratory. So that is Rome, okay? And then we have a up arrow for metabolic, which is not Rome. So this client is respiratory acidosis with the kidneys coming to compensate, and it's fully compensated because the pH is within range, okay? So pH 7.35, it's normal, but it's normal low. CO2, abnormal, not a lot, but it's still past my 45, so it's high, put an up arrow. HCO3, it's past my 26, put an up arrow, okay? So you have everything abnormal here with these two. They're both abnormal, but one of them is doing Rome, okay? And the one that's doing Rome is the respiratory system. So that's your original problem. Respiratory acidosis fully compensated because your pH is within range. All right, I know that section is heavy. Any questions before I move on? Okay, while you think of your questions, this table, really you need to spend a moment with it because you need to know what condition causes acidosis, what conditions causes alkalosis, okay, right? So you need to spend time with the signs and symptoms and know what condition. So any condition that traps CO2 will cause acidosis, okay? For example, hypoventilation. Hypoventilation will cause acidosis because you're holding on to CO2. Okay, hypoventilation are those people who breathe slowly versus hyper, they're blowing off CO2. Okay, your diabetic ketoacidosis. Okay, they're holding on and they're breaking up fat, which leaves behind the ketones. Hence the name ketoacidosis, okay? Of course, lactic acidosis, renal failure. So all of those conditions will cause metabolic acidosis, but when it's the respiratory system and you're holding on to CO2, that's respiratory acidosis. Now, conversely, any condition where you're increasing base, okay, will cause alkalosis, okay? Or you're blowing off too much CO2, which will cause alkalosis. Okay, so hypokalemia will cause metabolic alkalosis, whereas hyperkalemia will cause acidosis, so vice versa, and you see that both here. Now, imagine a balance. So let's say you are acidotic, right? The only way you're gonna fix acidotic condition is by getting rid of acid or adding base. That's the only way you're gonna fix it. So you have to stop and think about the condition and how to fix it. About the balance, I'm acidotic, I need to either get rid of acid or add base. That's how you're gonna balance that scale, hence the scale I was at the beginning. So you gotta spend a little time with this. One more thing I wanna point out, the paper bag question. So when do we give the client the brown paper bag? When you want them to pick up CO2. Okay, so when they're alkalosis, okay, so that means too much base. So there's only two ways you're gonna fix it. You're gonna either get rid of base or add acid, okay? So the way you add acid, you add CO2 is by having them pick up that CO2 that they're blowing off. So they breathe into the paper bag, they blow off the CO2, they breathe it back in because of the paper bag. So think about what it is that you wanna do, okay? You want them to pick up CO2, the paper bag, okay? So you gotta spend a moment with that chart. These are just little mnemonics. The treatments, which is on the chart. One more NCLEX question I want to point out with is when you're correcting acidosis. When you're correcting acidosis, it doesn't matter how much oxygen you give, you've got to blow off CO2. That's the problem. Respiratory acidosis, the only treatment is to blow off CO2. So if they're on a ventilator, put them on a PEEP setting so they can blow off that CO2. Giving them oxygen sounds like a great answer, but it's not the best answer, okay? All right, we're going to talk about some conditions. I'm keeping track of the time, of course. So arterial blood gas we've covered. Blood culture, when you're doing a blood culture, don't forget you wanna do the blood culture before you start your antibiotics, and that makes sense. Because if you start your antibiotics and then do the blood culture, you're gonna get a false low, especially if it's a broad spectrum antibiotics. All right, let's talk about bronchoscopy. So with the bronchoscopy, don't forget, you numb the trachea and the epiglottis as you go down. So post a bronchoscopy, you need to assess and make sure that gag reflex is back. And they're always NPO before this test because of risk of aspiration. Okay, so post a bronchoscopy, check your cranial nerve, do that gag reflex, literally stick a tongue blade down their throat. If they gag, then their sensation is back. If they did not gag, they don't have sensation, they will aspirate. Whatever you give them will go into their lungs, okay? PFT, pulmonary function test, we covered last time. We covered thoracentesis, we covered the PPD. Okay, a couple of conditions with the little ones I want to go over. Don't forget, we talked about surfactant to death. So here's a nice picture of the alveoli. There's a nice alveoli with surfactant, and then another one collapsed without surfactant. Here's a nice picture of surfactant. So if you have a child who's born prematurely or car accident or drowning where the surfactant gets washed out, they're going to need to be on a ventilator. But we can add surfactant directly into the trachea, so it goes into the alveoli of these children and monitor them and see what happens. Okay, but they'll end up in respiratory distress, okay? And there's acute respiratory distress, and then there's adult respiratory distress as well. So these children and adults end up on a vent. All right, so I'm going to go through disorders and pull out NCLEX stuff because we have like disorders after disorders after disorders. It's gonna be like boom, 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 boom type of thing. Okay, so wake up and stay with me, okay? So next one is apnea. So you have a child who's born and they have cessation of breathing. It is not a problem until they're doing it for 20 seconds. So once they're having that apneic episode for 20 seconds or greater, they need to be on an apnea monitor. So NCLEX question, this child will go home on the apnea monitor. You can see here in the picture, it wraps around them when they do this apneic episode. It alarms everybody. The other NCLEX question deals with the BLS training. The parent and caretakers of this child with apneic episode cannot go home unless they've learned CPR because they may need to practice CPR on this child. So those are the NCLEX question concerning this condition, okay? The common cold, sinusitis, you can go over. I want to cover tonsillitis. So you may have to care for a patient post a tonsillectomy, okay, due to tonsillitis. So there's a lot of NCLEX question post the removal of the tonsils. The picture you saw earlier is called kissing tonsils, where they're so close to each other because of that edema. So now nursing intervention, post a tonsillectomy, the patient may have what we call the frequent swallowing. They're not swallowing saliva, okay, they're hemorrhaging. All right, so you want to assess for bleeding. Also, for these clients, put them sidelined. So if they do, have all that excess blood, it'll come right out of their mouth. Put them on the side so they don't aspirate that blood. Second, never give them anything red or acidic. The color is because if they throw up, is it what you fed them or is it blood? We don't know. So no red food and no food that's acidic because then it's going to aggravate the sutures, okay? No aspirin for these children because this could have been from a viral infection because they're caused by virus, bacteria, a number of pathogens. So if it was viral and you give them aspirin, they're at risk for Ray's syndrome, okay? And they recover from this, within a week or two. No exercise or swimming, those are not a big deal. All right, the next condition is croup. Croup is special. Croup is multiple conditions. It could include laryngitis, tracheitis, or epiglottitis, and/or. The worst one here is epiglottitis. So with epiglottitis, remember I showed you a little picture of the epiglottis, which has a very important job, okay? We don't want the epiglottis blocking the airway, okay, which would be a medical emergency, and that is what's happening. But these children with epiglottitis present a very specific way, which we call the 4 Ds. So learn the 4 Ds. The 4 Ds are, they are drooling, D number 1. They're dysphasic, okay, dysphagia, difficulty swallowing, D number 2. That's why they foam at the mouth. They can't even swallow their own saliva, okay? Dysphonia, they have that hoarse sound to their voice, okay? And distress. Why are they in distress? Because of decrease in oxygen going to their lungs. So these are the 4 Ds: drooling, dysphagia, dysphonia, distress, okay? So you have a child who comes into the emergency room and they present with the 4Ds, there is a certain way for you to handle this child. They're at risk of something happening called laryngospasm. That is the airway shutting down, okay? So the airway could close on you, okay? Their pulse will increase, their heart rate will increase, they're gonna be restless, they're gonna be retracting, okay? So one of the things that causes laryngospasm is when you tell that child, open your mouth, let me see. So it is imperative that you do not attempt to visualize, okay, epiglottitis, because you end up causing laryngospasm, okay? So NCLEX question, never attempt to visualize the child's airway with epiglottitis because you'll cause laryngospasm. So when they come up presenting with those 4Ds, prepare for an emergency tracheotomy, okay? That may be necessary, okay? Now let's do some lower respiratory problems, okay? Especially asthma and COPD. I wanna go over, but let's do pneumonia real quick. So pneumonia, you see a nice, beautiful alveoli here in the picture, and look at the one on the right with the fluid building up, right? So these are some acute infection of the lungs. It could be bacterial, fungal, viral, a number of things could cause the pneumonia, coronavirus. So pneumonia leads to death, especially in the elderly, so we take this seriously, okay? So with pneumonia, we want to get rid of that excess fluid. And with the elderly, we could give the pneumococcal vaccine to prevent it, number one, okay, that would be great. But you can see with all that excess fluid in the alveoli, it's gonna be very difficult to exchange. It's gonna be very difficult for them to give off that CO2 and pick up that O2, okay? The coughing, the fever, the chills, the tachycardia, the heart's trying to compensate, okay, tachypnea, dyspnea, okay, so all of those are signs and symptoms of the pneumonia. So treatment, we're gonna do the ABGs as a diagnostic test. We're gonna do the chest physiotherapy, the sputum check. All of that goes with diagnosing it, but treating it will depend on the cause of it, okay? So depending on the cause, we will treat, if it's bacteria, the antibiotics, okay? If it's viral, it makes it very difficult to treat with the virals. So a lot of time it has to take its course, but we can help get rid of the excess fluid and things like that. But another thing, if they end up in antibiotics, remember, teach them to take the entire course of the antibiotics, because remember, when you don't take the entire course, you end up becoming very sensitive to it. Next time it doesn't work, you build resistance to it. Next time it doesn't work. So you have to teach client, even when you feel better, finish the dose, okay? Now, cystic fibrosis. So cystic fibrosis is an autosomal recessive disorder. So these are the children with the thick mucus. Not only does cystic fibrosis affect your respiratory system with the mucus gland, it also affects the digestive system, okay? And their reproductive system, okay? And their sweat gland. So let's go over a couple of diagnostic tests for cystic fibrosis, and then we'll go over treatment with the bronchodilators, the steroids, and the mucolytics, okay? This little mnemonic has a mistake, and I want you to be aware of that so you can fix it, okay? And you don't get messed up on your NCLEX questions. So it says here, diet is low fat, it's high fat, okay? And I'm gonna tell you why for your NCLEX question. So your cystic fibrosis client have a great diet, high fat and high salt. Can't get better than that. Why do they have a high fat diet? Because they have a little condition with this disorder called steatorrhea. Steatorrhea is when they're pooping fat, so hence why they can have a high fat diet. And don't forget, one of the ways we diagnose this is with the sweat chloride. So these children, literally, we put the little patch and we cause them to sweat, and when we analyze it, it's very high in sodium and chloride. So they lose salt literally through their skin, hence why they should have a diet high in salt. Okay, so again, great diet. And a lot of time when the newborns come and they don't have that first meconium, we want to look into that. So a couple of different ways we analyze this one. So treatment, one of the first treatment we want to do is the bronchodilators. Let's open that airway. After we use the bronchodilators, if they have edema, then the steroids will be a part of that. If not, then we go to the mucolytics. We want to thin that mucus, make it easier to cough up. Okay, and then we want to do the chest physiotherapy, okay? And these children should stay hydrated. It makes those mucus easier to come out. So the chest physiotherapy, you could do with your hand. Don't forget, you need to cup your hand, or we have the vest. Don't feed the children and then do this. It should be a good 2 hours apart. Give them time to digest their food, or else they might throw up, okay? Don't forget, increase their fat-soluble vitamin. Same reason with the increase in fat content because of the steatorrhea. So if they're pooping fat, they may be depleted of their fat-soluble vitamins, okay? The best exercise, by the way, for this child is swimming, okay? That's right here, swimming, no sports, no contact sports, okay, for this child. All right, asthma. So asthma is a chronic inflammatory disorder of the airway. So asthma is one of those conditions that have remission exacerbation. Remission exacerbation. You could go a long time with no asthma attack and then boom, something aggravates it and here you go. So if you know the cause, eliminate the cause, okay, but the problem is bronchoconstriction. So we're gonna talk about some bronchodilators, okay, for these conditions. You see a nice, beautiful open airway. Here's an asthmatic patient here on the right. So these patients wheeze a lot because wheezing is air trying to go through a tight, tight, tight space, okay? So in addition to everything, we're gonna do a pulmonary function test. We wanna see their exchange, okay? So your medications are going to involve the bronchodilators, it's gonna involve the steroids, and we have a combination of them. I'm gonna cover them together because the COPD drugs go together. So I'm gonna cover these drugs in a moment, okay? Your steroids with your bronchodilators, okay? But these are the family of drugs we use to treat these, okay? Your inhaled corticosteroids, your long-acting betas, and your short-acting betas, and some anticholinergics. So we're gonna cover those together because we use the same drugs for COPD. So some of them are good for asthma, some are good for COPD, some are good for both, okay? So we're gonna cover them together. So COPD is next. So COPD is a broad umbrella. Under COPD, you could have emphysema, you could have bronchitis, okay? But some commonalities within the two disorders and some differences, okay? Both of them, these guys have a problem with accumulating or holding onto CO2, okay? But the pathophysiological process or the problem is different. So emphysema, the alveoli loses its elasticity, whereas with bronchitis, there is inflammation and edema, okay? Itis tells you that. So bronchitis, though, they have cyanosis, okay? So we have a little nickname for them called blue bloaters. And then emphysema, they don't get cyanosis, so we call them pink panther, okay? If you ever heard of these, here are these little mnemonics. I like these artists. All right, so a couple of commonalities, okay? So for both of them, we're gonna talk about bronchodilators, steroids, expectorants, but both conditions, they do a little something we call pursed lip breathing. And NCLEX wants to know why do they do the pursed lip breathing? So they'll breathe in, and then they breathe out, and they keep blowing out. Why do they do that? Because they're getting rid of that excess CO2. And then that's why they usually end up on a CPAP, BiPAP machine, because we put it in the setting where they do that. They get to blow off that CO2. Okay, so another NCLEX question with your COPDers deal with the oxygen. We talked a little bit about that, the last client needs categories we covered. So your COPDers, you saw earlier, I showed you how neuro is connected to respiratory, connected to cardio. For you and I, when we're low in oxygen, you know, our brain knows, okay, take some deep breath, okay, to get that oxygen in. Your COPDers have a different mechanism. When you give them too high flow of oxygen, they stop breathing, okay? So you can only or should only give them 2 liters on the nasal cannula. Okay, never a non-rebreather or anything like that. So the question that tells you, you know, you walk into the room, what should you intervene, that oxygen for that COPD should not be more than 2 liters. Remember, they sat in the 80s and they're fine, okay? All right, let's talk about some of the medication. So your inhaled corticosteroids, okay, inhaled corticosteroids and long-acting beta agonists for asthma and COPD. So your inhaled corticosteroids are our first line defense for your asthmatic patient. We can use them for COPD, but they're more for asthmatic. Whenever you have steroids involved, thrush is a possibility, is a risk factor. So you know you have to tell them, rinse out your mouth. Even then, they still, a lot of them end up with the white cheesy, that's a fungal, okay, with the thrush. So some physicians even prescribe an antifungal with the medication because of the risk of that. So fluticasone, okay, Flovent, Okay, inhaled and nasally, it comes in both formats. Okay, budesonide, Pulmicort, you're very familiar with, come in both formats as well. They're usually BID. Okay, your long-acting or LABA, okay, they work on the beta receptors in the lungs. We talked about that earlier. So those are better for COPD, not asthma. Okay, you can do it for asthma, but it can't be the only therapy. It can't be a monotherapy for asthma. Okay, so we're talking about your salmeterol, Ceravit, and your formoterol. Okay, there's combination drugs where you have your fluticasone, we just talked about earlier, plus salmeterol. So it's a combination of your inhaled corticosteroids and a long-acting, okay, which is Advair. You're more familiar with that term. In Symbicort, nice Symbicort commercial. Okay, some of them come in meter dose inhalers, some of them come in a dry powder, you know, it breaks the pill, and then some of them come in nebulizer treatment, like Pulmicort you're familiar with. All right, so now we also have these short-acting beta agonists plus anticholinergic. Now, you know, if there's an anticholinergic with it, the dryness, okay? So I'm done saying that. I sound like a broken record. Albuterol, which you're very familiar with, okay, Ventolin, Proventil, usually they provide, you know, 2 inhalation every 4 to 6 hours. It works on the beta 2, okay, that we talked about earlier, great for both conditions, okay. Levobuterol, Xopenex, works on the beta 2 as well, okay, for COPD and asthma, but both of them will cause the tachycardia. Tell the patient that. You may feel your heart racing, risk for tremor and hypertension. So if a client already has a hypertensive condition, then this is not for them, okay? That's why we need to do a history and physical, okay? You have some short-acting one, okay, ipratropium Atrovent, used for COPD as a rescue, not as a controller. Okay, so also pay attention. Is this an acute or a chronic? Okay, what am I doing here? So not for asthma. This one is for COPD. Okay, don't forget cholinergic, dry mouth, constipation, blurred vision, urinary retention, blah, blah, blah. Okay, dryness. It's just the family of the drug that does that. There's nothing you can do about that. Spiriva, great for COPD as a controller. Okay, you saw here how Atrovent is great for rescue. Okay, so Spiriva is controller, and then we have a combination, albuterol and ipratropium. Okay, that's Cumbivent. So that's for COPD, not for asthma. So great little table here. Okay, you can go over that. All right, TB. TB is special. Yes, it is, especially the drugs. We got to go over the drugs. So with Mycobacterium tuberculosis, obviously that's bacteria. Let's talk about how you diagnose it. So that nasty, lovely bacterial infection is diagnosed with 3 sputums, 3 separate mornings, okay? So in addition to positive sputum, you have the weight loss, the anorexia, the night sweat, the chest pain, then you get diagnosed with tuberculosis. You need to be isolated. We've already talked about that component of the disease. You're gonna be in the negative pressured room, you have something we don't wanna spread to the general public, that type of stuff. Don't forget the x-ray, the PPD, none of that diagnosed you with TB, only the sputum, positive sputum, 3 of them. Okay, 3 separate mornings. We already talked about the PPD and the chest x-ray with the other client needs categories. Okay, pulmonary embolism, I want you to pay attention to the signs and symptoms. You know, when a client has pulmonary embolism, dyspnea obviously is the first sign, cough, the chest pain, the anxiety, the tachycardia and tachypnea. So know the signs and symptoms of a pulmonary embolism. And you know this could happen post-surgery, especially the first 24 hours. You had a long bone surgery, fat could have dislodged and go and block the pathway, or it could be a deep vein thrombus if you've been bed-bound, bed rest for too long, and you didn't have any embolic stocking or compression boots, nothing like that. You're at risk of a deep vein thrombus dislodging and causing a pulmonary emboli. Or you could have had endocarditis. You develop these clots that travel and block the pathway, but know the signs and symptoms, okay? Some clients that are prone to them, we could put a filter to catch them, okay, if you're prone to it. All right, chest tube. We need to talk about chest tube. So you have air in the atmosphere. So we call that atmospheric air, okay? So the atmospheric air doesn't belong in your chest, okay? So some client, if they have a puncture, okay, so that would be an open pneumothorax where air, the atmospheric air gets in your lungs, or it could be a closed pneumothorax where there is no puncture, but then you have air bleed in your thoracic cavity. That is a medical emergency. If you allow that atmospheric air to continue to enter the lungs, you could have what you call pressure or tension, pneumothorax, whereas you see in the picture here, it's gonna move every organ to the other side. These clients need a chest tube, okay? You could also need a chest tube if you have blood, hemothorax, blood in the pleural space, empyema, pus, purulent drainage, chylotherapy, lymphatic fluid, okay? So pleural effusion itself is just fluid, okay, in the pleural space, but it could be blood, it could be pus, it could be lymphatic fluid. All of these clients need a chest tube. So let's talk about chest tube. I did it briefly when we did the other client needs category, but we need to go into a little bit of details here. Couple of NCLEX questions. Number one, never lift the chest tube device above the insertion site, because whatever's coming out of their blood, pus, empyema, whatever it may be, could go back into the client's chest and cause a nasty infection. So never lift the device above the insertion site, okay? That's one. Two, the chest tube have 3 chambers. There's the water seal chamber, there's the suction control chamber that connects to the wall, and there's the collecting chamber. Now the chamber, you need to know the fluctuation, the water fluctuation in each chamber, what's expected. So in the water seal chamber, that is the chamber that mimics the client. The client breathes, bubble, bubble. So that chamber has intermittent in and out bubbling, okay? Whereas your suction control chamber has ongoing continuous bubbling, okay? So if you don't see what you expect, something is wrong. So for example, if we're talking about water seal chamber and you don't see intermittent, you see continuous bubbling, there is a leak somewhere. You need to find it. And vice versa. If you're looking at the suction control chamber and you don't see continuous bubbling, there's a kink. You need to find it, okay? And there's also NCLEX question about chest tube when the chest tube dislodges. So if the chest tube comes out of the client, that's why you need that Vaseline gauze at the bedside. You wanna put that Vaseline gauze where the tube came out of, if it came out of the client, and you wanna tape it in 3 sections, okay? Vaseline gauze, tape in 3 sections if the tube comes out of the client. Now, if the tube comes out of the device, you need the hemostat, the scissors that clamp, and you need to put that tube in the bottle of normal saline that's at the bedside. Couple more NCLEX question I want to pull from this. There's a special assessment you want to do for clients with chest tube called crepitus. You want to put your hands around the insertion site of where the chest tube is and feel for any type of air bleeds underneath your skin. You'll feel it, like go under your skin. That's air bleed. You need to let the physician know about that. Okay, so that's called crepitus. So you're assessing for that. Okay, and you know this tube is ready to come out when the client has very little fluid coming out. So you have less than 150 ml in 24 hours. It's time for this tube to come out. Also, we measure the amount of fluid at the end of our shift. That's somewhere here. At the end of the shift, not 8 hours, or 4 hours at the end of your shift. You mark it with a marker and you write the time. So at the end of the shift is when you mark how much fluid or pus or blood came out of the tube. I want to go over the tuberculosis drugs, okay? We kind of did everything else. And this is a very nice chart, by the way, comparing the relievers with the controllers with the combination. So I did those already. I want to do the TB drugs, and then we're done with respiratory. Let me see the time. Okay, so your anti-TB drugs. So your anti-tuberculosis drugs, you need to remember TB is treated with what we call a cocktail. So it's never one drug. You will only see one drug if the client is immunosuppressed and they've been exposed, not that they have TB. But if you have TB, it's a cocktail, okay, a combination of drugs. So for TB, you have your first line defenses and you have your second line defenses. Your first line defenses are the INH, isoniazid, rifampin, ethambutol, pyrazinamide, and streptomycin, okay? Your second line defenses are over here, okay? Cycloserine, kanamycin, those are very strong antibiotics, okay? And by the way, TB drugs, you're not on them for a month or 2, they range from 6 months to 2 years, okay? You could be on your TB drugs for years. So each TB drug have a little craziness you need to remember and keep in mind. So I'm gonna go through each of them and pull out that little craziness you need to remember. So isoniazid, they're the ones who cause jaundice, okay? Hepatotoxicity. Okay, that liver breaks down. They get jaundice, as you can see in this picture, and they get another little problem called neurotoxicity. So neurotoxicity is that numbness and tingling that they feel like a diabetic, you know, that feeling. So isoniazid causes that. Okay, so we always give isoniazid with vitamin B6. Okay, oops, right there. And with the alcohol, no more alcohol. Like, you knew that. All right, rifampin is the one that causes your body fluid to turn orange. So this one needs to be taken with a lot of water, okay? Rifampin does that, okay? Of course, no more alcohol. Paracetamide is the one that causes you to be sensitive to the sunlight. And it also causes you to act like a gout patient. I've already covered gout. So when you're on paracetamide, it increases your uric acid, which causes all these crystals that loves the big toe. Okay, so, and also they're very sensitive to the sunlight. So tell them, don't go out in the sun between 10 and 2, wear a sombrero, wear a long sleeve, wear your sunscreen, okay, because the UV rays are too high. So paracetamide causes that. Ethambutol affects your vision, okay? So that visual acuity test, okay, with the Snelling chart needs to be done like every 4 to 6 months, okay? Your streptomycin are very toxic, okay, to your kidneys and to your hearing. So they cause nephrotoxicity and ototoxicity, okay? So I want to check that cranial nerve 8 frequently. So that was all respiratory. There are questions at the end of respiratory. So now I'm going to go to neuro, okay? If you have any questions, send them now. I know we're going like boom, 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 but we don't have a choice, okay? There's a lot to cover. So neuro, let's start with the brain. There is a hotspot question with the brain, okay? So you do need to know the different areas to the brain and their purpose, okay? So you can see here, the biggest section is the cerebrum, okay? So the cerebrum has a frontal lobe, it has a parietal lobe, it has a temporal lobe, and it has an occipital lobe. And each of them have their function. Okay, so you do need to spend a little bit of time with this and knowing what each area's function is. Because I could give you an example, tell you the client had a motor vehicle accident where the temporal lobe was affected, and you need to know what changes you would expect. So if it's the temporal lobe, you're talking about it affecting their emotional response, their memory, their language. And if it's the occipital lobe, their vision. So you see what I'm saying here. The cerebellum deals with balancing. The fact that you can walk straight and you can close your eyes and not sway to the side and fall is because you have an intact working cerebellum, okay? Your brainstem is also an important function, okay? So that has the midbrain, the pons, the medulla oblongata, okay? Your breathing control is there, so that's kind of vital. We want that to be working, okay? So now the other part I want you to keep in mind is the cervical spine. So you see here, the first 7 are the cervical vertebrae, and then you have your thoracic, your lumbar. We're going to talk about trauma, okay, to those areas. So this is quick anatomy. For example, if you get an injury at C3 or above, you're for sure going to be a quadriplegic, okay? So we're going to talk about that. Your cranial nerves are next. So you need to have a little mnemonic for these. I don't know how you can bring them to memory without a mnemonic. Okay, there's 12 cranial nerves. You do need to know who they are, what they are. Are they motor, sensory, both? Like, yes, you do need to know all of that. I don't know which one they're going to ask you in the NCLEX, so you got to work on all 12 of them. So here they are here, the little mnemonic that I have memorized. Okay, there's a bunch of them out there, and you can, of course, make your own. So here's one: olfactory, optic, oculomotor is on, old, Olympus, towering. Some students have that memorized. I know the old one, O, to touch and feel, you know, that's the one I memorized. You also need to memorize whether they're motor, sensory, or both. Some say Mary money, but my brother says bad blood, Mary's money. So you need to memorize something. So for example, let's say they're questioning you on the trigeminal nerve, right? So some say Mary money, but. So I know that the trigeminal nerve has both a motor and a sensory. That's that nerve right on the side of your mouth that causes tic-douloureux. Okay, we're going to talk about tic de la rue. So you see how why you need to memorize these and the reason. So you may not even get a cranial nerve question. I don't know. Okay. So the next slide, what I do is I go over with you how to assess them so you can spend a little bit of time on those. Headache is not major. You need to focus on the headache medications. All of them, well, yeah, I believe all of them end with triptan, if not all, most of them end with the word triptan, as you can see here. Almotriptan, rizatriptan, okay? So, and they're contraindicated in some patients, but usually you just need to know what they are. So seizures. So what are seizures? Seizures are abnormal, excessive overfiring of electrical discharge in the brain, okay? So we want firing, just not too much of it, okay? Remember homeostasis. So epilepsy is when you have 2 or more seizures, okay? So it's a chronic disorder which repeats itself. So these are just terminology. Generalized seizures versus partial seizure. Generalized, you're using the entire brain atmosphere, whereas partial is a part of it. These are great little charts to show you those. So tonic-clonic seizure. So I wanted to go over this one. Tonic-clonic seizure has 2 components. Okay, you see how where this child gets very rigid and then they have the abnormal movement. So the moment, you know, a client has a history of that or is diagnosed with that, they get even hospitalized for something else, you want to put them on seizure precaution. We're going to talk about that. Status epilepticus is a medical emergency. Those are the clients who they seize and the seizure lasts longer than 5 minutes, or they have repeated seizures where they never regain consciousness for over 30 minutes. That's a medical emergency. It could kill you. You see here, seizures lasting more than 10 minutes can cause death. So sometimes you have a client have a seizure and then the seizure's over, they know who they are, where they are, they know, they regain consciousness. So sometimes you have clients who have several seizures and they never regain consciousness. It's like you have an ongoing seizure, okay? So keep that in mind. A number of causes for seizures. Drugs could cause seizures, infections could cause seizures, high blood pressure could cause seizures, metabolic imbalance could cause seizure, head trauma. We could go on and on, okay? So we want to assess. Some clients get an aura before their seizures, okay? So we want to know what they're on, what medications they're on. Are they on any herb? Do they abuse alcohol? Are they on, you know, illicit, illegal drugs? So we want to do all of that, okay? We're going to do an EEG, a CT, MRI, PET scan, all of those will help us diagnose, okay? But what we're going to focus on for NCLEX is what do we as a healthcare provider do before the seizure, during the seizure, after the seizure, okay? So before the seizure, the client should be in seizure precaution. And we've talked about seizure precaution in past lessons where there are 3 things you need to do to be deemed on seizure precaution. You need to pad the side rails, or we have seizure boards, okay? They're soft, so if the client hits them, they don't end up with a concussion. You also need 2 things at the bedside. You need suction and you need oxygen at the bedside, okay? So once you do those 3 things, the client is on seizure precaution. So that is before the seizure. Now, NCLEX question during the seizure. So during the seizure, there's a lot of safety components, okay? First of all, we never leave clients who are seizing, so if that's one of your answers, get rid of it. If the client is standing up, you want to break their fall. That's a safety thing too. You come behind them, you put your leg between their legs, you lean them on you, and you slide them to the floor. That's how you break their fall, okay? Put a pillow underneath their head. Loosen anything that's tight, right? Tie, a belt, shoes, right? Loosen all of that. Do not put anything in their mouth. That is old practice. If you see those, by the way, in the NCLEX 4000, just know the proper information because the NCLEX 4000 is old, but it is still a good product to use, okay, to practice questions. So you just need to remember that. That's old practice. Do not put anything in their mouth. Do not hold them down. Okay, we want to look at the airway, breathing, circulation, look at what time it started, look at what type of movement they were having, okay, because that's where we come in and we document. Notice if they had incontinence, okay, what brought it on. So these are great little things to keep in mind. Now, after the seizure, put them in the recovery position like you see in this picture here, side lying. If they vomit, it can come right out of their mouth. Allow them to rest. We don't ever give seizure medicine during a seizure. It's always after. Okay, So remember, when you're documenting, never come out and say patient had tonic-clonic seizure. If you do that, you're outside of your scope. That's a physician diagnose, okay? So we would never do that. We would describe, okay, patient was rigid, abnormal movement, flexion, extension, like we would describe. We would never come out and say that. So teaching, clients with seizure that are older, that drive, they cannot drive anymore. So we take your license away and you need to be seizure free for at least 6 months before you can drive again. The 6 months varies from state to state, but you know that we say 3 to 6 months of seizure free. You also need to teach this client. There's some lifelong measures, okay? No more going to the bathroom and locking the door. If you're having a seizure in there, how do I get in? I gotta break the door. No more going swimming by yourself. As a matter of fact, these clients should not be alone anymore. The school that I'm teaching out, there's we had a director there. She was new maybe about less than a month. And she has a daughter who has a history of seizure. She goes home and she finds her daughter dead. Her daughter had a seizure and nobody was there. This is crazy. So folks like that should not be alone, and they should always have a medical alert bracelet on. That's an NCLEX question. Okay, have your medical alert bracelet on, and they shouldn't be alone. They shouldn't fly, okay, because that increases the risk of the seizure. The little ones that ride their tricycle should have their helmet. So there's a lot of, lifelong changes for these clients. But yeah, it's very sad. They should be with someone all the time, because this doesn't warn you. It could happen anytime. It could happen while they're driving. Okay, it could happen while they're swimming under the water, and God forbid nobody's home. Here's a tragedy like I just explained to you. Very, very sad. That was heart-wrenching when we heard that. All right, let's go over your seizure meds. Some of them you need to remember their therapeutic range. I'm going to tell you which ones. So here's a quick list for you. Phenytoin is very popular. Keppra is for sure in your NCLEX. That's the one we use for the little ones, for children. Tegretol is another popular one. Depakote, valproic acid. So let's go. Let's talk about the drugs. The first one is phenytoin. So with phenytoin, you do need to know a couple of things. So first of all, phenytoin is one of those you can build sensitivity to it. Okay, so they will need to have their blood drawn for this one. So that's a little high maintenance, right? And don't give phenytoin with Coumadin, okay? Because they interact, okay? So be careful with that. And the other thing too, phenytoin is a little high maintenance because you also need to teach the client to stay away from citrus juice. No more grapefruit juice, no more of those. They gotta come out of your diet. Okay, and if you look at my list online of drugs that interact with grapefruit and grapefruit juice, you'll see phenytoin on there. Okay, and then you'll see a lot of the calcium channel blockers on there also. They don't mix with grapefruit and grapefruit juice. The other thing with phenytoin you need to memorize is therapeutic range. It's on your list, okay? So you're memorizing that. The therapeutic range for phenytoin is 10 to 20 microgram per milliliter. So they get toxic on that once it goes past, 20. So monitor that. Don't mix it with ginkgo as well, ginkgo biloba. I have a herb sheet that I need to put online. I will. Okay, your next family are the barbiturates. So the barbiturates are the phenobarbital, okay? Most popular one. So this one, I would be careful with it if the client has a history of respiratory problems, okay? Because there's a possibility of respiratory depression with this one, so don't mix the two. Your next family are the benzodiazepine, which we talked about the benzos already under psychiatric nursing. Yeah, we did cover those already. So, but just to recap, so diazepam, Valium, we've already talked about. So Valium is also used as an anticonvulsant. Okay, that's your emergency drug of choice. Okay, great for your absent seizures. We can give it IV, we can give it by mouth, but respiratory depression is a risk, okay? Here's another family, your succinimides family. They compete with GABA, okay? So never mix these with alcohol, okay? They're not as popular as the others, okay? Valproic acid is your valproic acid family. Valproic acid Depakine, okay? Depakote is used for bipolar, so don't mix Depakine with Depakote. Okay, so valproic acid is Depakine, Kene. Check their liver function, with this one, and also you need to memorize the therapeutic range for valproic acid. It's on your list, 50 to 100 micrograms for this one, and if they come extended release, so don't crush them, break them, cut them, nothing like that, okay? Your immunostabine family, they're not as complicated. Tegretol, there's not too much to remember about those. We like that. Okay. Your phenytoin family, not as popular either. Okay, but just know where they belong as far as their family. Keppra is important. A few students have told me Keppra is on their test. Okay, levetiracetam. So Keppra is your drug of choice for pediatric patients, okay? For your little ones, your children, that's gonna be your drug of choice, especially for generalized absence epilepsy. So they come in extended release again, so you know what to do with that, okay? All right, let's see. Oh, time-wise, I have 36 minutes. Okay, so let's talk about infection to the brain, meningitis. So meningitis is on your NCLEX. A couple of things you need to know about meningitis. So the covering, the lining of the brain is infected, okay? It could be from a bacteria, it could be from a viral, it could be from a fungus. So your contagious one is the bacterial one. So you isolate every meningitis patient at first until you know which meningitis you're dealing with. So again, everybody gets isolated with meningitis, so they come into your emergency room, you don't know if it's bacterial, viral, fungal, isolate them, right? Once you find out it's bacterial, they will stay on isolation. Your virals and your fungals can get off isolation because those two are not contagious. Bacterial meningitis is contagious. So you keep that client on isolation and you start your antibiotics. So 24 hours after you start your antibiotics, they can get off isolation. Okay? After 24 hours and being on antibiotics, they're no longer contagious. Okay? A couple more things with meningitis. So there's a group that is more prone to catching this than others, and those are your college students that are sharing a dorm, okay? So that's here. Make sure you remember that, okay? Couple more things, well, a few more things with meningitis. Their meningitis has a couple of specific diagnostic tests, okay? Those diagnostic tests are specifically for meningitis, okay? So one of the things we look for, they're gonna have the headache, the sensitivity to light, all of that stuff. But one of the things we look for is that nuchorigidity. The back of their neck is very painful, okay? They have severe pain to the back of their neck, especially when they flex it. So that's one thing we look for. The other thing we look for are Koenig and Brodzinski. And students have told me they've had these questions with pictures. I use the same pictures NCLEX use, and they have multiple choice with these questions. So let's go over Koenig's and Brodzinski. So Koenig is the top left picture. So Koenig, you put the client supine, put them on their back, take one leg, flex it and extend it. When you extend it, the client with a positive meningitis, this will be very painful for them. That's Koenig. Knee starts with a K, okay? That's how I remember it. So if it helps you, beautiful. Brodzinski, lay the client supine, flex their head. Literally get their chin to touch their chest. When you do that, they automatically, you don't have to do this part, they will flex their hip and their knees. That's positive Brodzinski, okay? The pain with Koenig is positive Koenig. The pain with Brodzinski, the automatic flexing of the hip and knee with Brodzinski is a positive Brodzinski, okay? Those are used specifically for meningitis, including the nuchorigidity, okay? We also do a lumbar puncture, but lumbar punctures are always contraindicated with increased intracranial pressure, okay? So anytime you see signs and symptoms of increased ICP, no lumbar puncture, okay? So if there's no ICP, we're gonna do a lumbar puncture and we're looking for sugar. Remember that. Decreased glucose will be in bacterial and fungal infection. Viral infection, you will have an increase in glucose, okay? So keep that in mind. All right, so let's see. The treatment depends on the cause. If it's bacterial, antibiotics, viral, we let it run its course, okay? We have a couple of degenerative disorders that we need to cover that are on your NCLEX. Okay, they're not heavily on your NCLEX, but you don't want to not know, what we're talking about or what they present like, okay? The first one is Parkinson's. We talked about schizophrenia, right? And we talked about your schizophrenic patient having too much dopamine, remember that? And then we talked about being having homeostasis. So then the opposite end of that is when we treat a schizophrenic client and then we deplete them of their dopamine too much, and now they look like a Parkinson's client. So this is the opposite end of the stick with these two disorders. So too much dopamine, schizophrenia. Not enough, Parkinson's, okay? So Parkinson's is due to a depletion of the dopamine neurotransmitter, okay? But you need to spend time with knowing how a Parkinson's patient looks. They have these specific signs and symptoms and findings. Okay, they're the ones with the pill rolling habit, right? Remember that? They're the ones with the shuffling gait, right? Forward, backward, forward. And then they have these resting tremens where body parts move without control. Okay, so keep all of that in mind. You got to spend a little bit of time with the finding of how they look. Okay, now treatment, by the way, these are called degenerative disorders for a reason. That means we don't have a cure for them. They will progress, and kill, right? So what we're doing is we're stopping or slowing down the progression of the disease. We're treating signs and symptoms, but whatever you've lost, like the brain function that has been lost, is lost. Okay, we're going to talk about some demineralization. Whatever's been lost is lost. We don't have any way of helping you to gain what you've lost. We can slow the progress of, you get what I'm saying? So that's why they're degenerative. They're going to continue until it kills the patient. Okay, so that's just the class of diseases we're talking about. Some of them are very sad. There's just no cure for them. All right, so with Parkinson's, you know we're going to try and elevate the dopamine level. Okay, levodopa, carbidopa. Okay, that's the purpose of these drugs. So we're going to put them on some anticholinergics, okay, to help with the extrapyramidal events. And you know these drugs are going to dry them out. Okay, we've already talked about your anticholinergics. We talked about atropine. So here's a couple more. Cogentin is an anticholinergic. Okay, procyclidine is an anticholinergic. So drink a lot of water, eat fiber, walk, you're going to get constipated, right? Tell them. All right, so PTOT-ST goes with those disorders, okay? So your golden standard or your drug of choice to treat Parkinson's is levodopa, carbidopa, okay? Mixture combination of levodopa and carbidopa, which is Sinemet, okay? That's your first line defense. That's your golden treatment, okay? All right, the others are great too, but I don't even believe they're on your NCLEX. Don't forget the anticholinergic, which we've already covered. We covered the dryness, the adverse effect to them. Let's go to dementia. Okay. So Alzheimer's is a type of dementia. There are a bunch of types of dementias. The most popular, prevalent one that is on your NCLEX is Alzheimer's. So Alzheimer's is the most common, prevalent type of dementia. So let's define dementia and then we'll go into Alzheimer's. So what is dementia? So dementia is a loss of brain function, okay? That happens with certain diseases where they have the memory loss, the scattered thinking, the inability to focus, okay? So that is the definition of dementia itself, okay? You have reversible dementia and you have irreversible dementia. We love it when it's reversible. We can fix it, we can do something about it. So reversible dementia are usually caused by, one, a UTI. So when they have a urinary tract infection, they act like this. The effective memory problem, the language, the behavior. So once you fix the UTI, you fix the behavior, you fix the dementia. That's why it's reversible. Sometimes folks will act like this, like they have a dementia problem when their B12 are low. Give them an injection of B12, you fix the problem. Some medications will cause reversible dementia. Do a medication reconciliation and you'll fix that. So those are reversible. Now, when the dementia is being caused by a debilitating disease, the disease is not reversible or treatable, so then the dementia isn't. As you see here, okay, we're going to talk about Alzheimer's, we're going to talk about Huntington, we're going to talk about multiple sclerosis. So if you have those disorders, which will kill you eventually, you cannot reverse that dementia, okay? That makes sense. Okay, so now dementia, we're gonna diagnose with CT, we're gonna do the B12 if that's the problem, we're gonna pull a urine to see, you know, if it's reversible. So management, we're managing signs and symptoms. There's no pill for dementia. There really isn't. So if they have psychotic episode, we're gonna have antipsychotics be a part of that. If they have mood issues, we're gonna have mood stabilizer. But you see how there's no pill for this, okay? So let's talk about Alzheimer's. So this is a great little mnemonic to remind you of the 5 A's that happen in Alzheimer's, and these are just vocabulary words. So when you get a moment, spend time with them. Okay, they have anomia, where they have the inability to remember the names of things, and also they pick up objects and not remember what objects it is and what it's used for. And aphasia, where the words they're trying to say cannot come out and they don't understand what you're saying. So spend a little bit of time with that. The other thing I want to go over about Alzheimer's is that Alzheimer's have stages. Okay, there's early stage, middle stage, final stage. That is in select all that apply and NCLEX question. So wake up, everybody. Early stage of Alzheimer's is the beginning of the madness, okay? Where they have difficulty thinking, they forgot that they paid the bill, they paid again, okay? It's very hard for them to decide, they seem a little frazzled. That's the beginning, that's early stage. And then you have middle stage, where it starts to affect their activities of daily living. And they start to have some psychological problem with the wandering, where they just get up and walk. Okay, or they act fine during the day, and in the evening, their behavior changes. Remember when we talked about, when we did psych, we went over all of these findings. Okay, so the hallucinations kick in. Okay, the wandering is very dangerous, so you always want to make sure you have a bracelet on them. They also have the sundown syndrome, where again they act normal while the sun is up. When the sun goes down, they have the hallucinations, the delusions, the wandering, everything kicks in after 7 or after the sun goes down. So that's usually middle stage. Final stage, they're completely relying on you. They have incontinence, they become mute, they don't speak anymore. I know one of the folks at the church is going through that now. It's very sad. And there's no treatment, there's no cure, there's no medication. You're treating, some signs and symptoms, you're ruling out some things that could cause it. So there are some pharmacological, but these pills are not to cure Alzheimer's, okay? Some of them you're very familiar with, they have a lot of commercials. So what they're gonna do, they're gonna inhibit the breakdown of acetylcholine in the brain, okay, to stop the brain from attacking itself. Razodine is a great one. There's a nice Razodine commercial. There's a nice Namenda commercial. So that one blocks receptors to slow calcium accumulation in the nerves of the brain. So again, we're trying to stop, okay, or slow down, but there's no cure for these. All right, Huntington deals with the basal ganglia. You see the basal ganglia in the brain for these condition, which is an autosomal disorder, as you can see here in the bottom right. So that starts to shrink, okay? It atrophies, it shrinks. So as it shrinks, it affects the involuntary movement, okay? It increases the client's involuntary movement. They can't control it, okay? They start to decline cognitively, okay? So there's some motor impact and some cognitive impact, okay? Their mental is also impacted. Not too many questions with Huntington. Don't need to spend too much time on that one. Multiple sclerosis, you see a nice spinal cord here on the top, and then here's a spinal cord that's going through demineralization. Okay, so obviously it's breaking down. So that's what's happening with multiple sclerosis. This is still being studied, obviously. But the other thing I want you to think of, this is not an old people disease. Young people catch multiple sclerosis as well, or end up with multiple sclerosis. So this affects the cranial nerves. They may have blurred vision, get very weak, okay? There's no pill, you see, there's no pill. ALS, Lou Gehrig's disease, this one has several names. You need to know all of them, okay? Amyotrophic lateral sclerosis, which is ALS, or Lou Gehrig's disease. So the spine, look at a beautiful spine on the left. This is a ALS client, okay? So these clients, the spinal muscle shrinks, atrophies. What you need to remember about this one, there's no cure. They'll die within 4 to 6 years, right? 2 to 6 years, as you see here. So usually it begins in the upper. So this is a condition we call a descending disorder. No cure, no pills, okay? Guillain-Barré is the ascending disorder. Don't mix them. Lou Gehrig is the descending. Guillain-Barré is the ascending, okay? Look at a nice peripheral nerve on the left, look at a Guillain-Barré. Okay, so this condition starts from the bottom. By the time it gets to the chest, they need to be on a ventilator. They usually die from respiratory failure. Again, no pill, no medication, nothing. Okay. Tic de la Rue. So you see this picture here where you have this large nerve on the side of your face. Okay, so that's called the trigeminal nerve. That sometimes overfires for these clients. And by the way, trigeminal nerve is also called facial neuralgia. It's also called tic de la Rue. And NCLEX does use tic de la Rue. I love when students come back and be like, what's tic de la Rue? I'm like, oh, cranial nerve number 5. All right. So the way you assess this, okay, you want to poke the client with something dull, something sharp. With my eyes closed, I feel that this is sharp. That's the sensation part. Have them open and close their mouths. You're looking for that click. Okay, so sometimes this nerve's overfires. Very easy to treat. Okay, we treat them with anticonvulsants that we just covered. We treat them with muscle relaxant like laoserol, great drug for that. But nursing intervention is where your questions come from. The client with this being triggered all the time, first of all, we want to find out what's triggering it. Usually it's extreme heat or cold. So if we know what it is, you can easily stop it. So avoid the draft, avoid hot and cold stuff, but teach the client, don't use that side. Okay, you're looking at sharp, painful firing on the side of your mouth like over 100 times a day. So very painful for them. So don't utilize that side, okay? Another condition that is similar but not the same is cranial nerve number 7, okay? That's the facial nerve. That's Bell's palsy. So this is where they get paralyzed on one side. So this client would not be able to blink on that side. They would not be able to chew on that side. As a matter of fact, this client needs to be on a puree diet, okay? You can't give them a steak. They can't run around, right? They can't do that. So let's go to the NCLEX question. You need to know and teach that client that they need to cover the eyes. They need to lose if a fly goes in there, they can't blink it away. They lose the ability to do that. This could last a short time and it could last for years. Okay, so teach them, use the other side, chew on the other side, pureed food, cover this eye, lubricate, ointment, patch. Okay, that's where your NCLEX questions come from for these. These are diagnostic tests. We went over MRI already. We went over CTs. I want to go over spinal bifida. What time is it? Okay, so spinal bifida, you see how the spine doesn't close all the way. You know, you can prevent this by taking your folic acid while you're pregnant, okay, to prevent this from happening. So the folic acid prevents the neurotube defects. So there are 2 types. There's the spinal bifida occulta and there's spinal bifida cystica. Occulta is the one on the top right hand here where you can only see it when you do an x-ray. Okay, that's minor. Sometimes they have a little shaft of hair, but no big deal. They're not paralyzed, nothing. When they have spinal bifida cystica, which could be meningocele or could be myelomeningocele. So this is true separation of the spine. So you see as the baby here, they have the protrusion to the back. We talked about this baby where this is the only baby who goes to sleep prone. Okay, so this baby, no diapers, no rectal temperature, no latex glove. Your job is to keep this moist and uninfected. Okay, so put a wet sterile gauze on this and take this child to the OR. We want to prevent infection for this because they will end up with meningitis, which we've already covered, or hydrocephalus. So hydrocephalus babies, that's the one earlier, it's not that prevalent on your test anymore, is where they need a shunt. They need a peritoneal shunt that goes from the ventricles of the brain to the abdominal cavity. So with those children, don't forget, no more contact sports for them. So this child too, no more contact sports. And whenever they have a peritoneal shunt, which shunts underneath the skull, don't put them on that side. They need to go on the unaffected side, okay? All right, let's cover Down syndrome. So Down syndrome, these children have an extra chromosome, okay? So you need to know what a Down's baby looks like, okay? So the Down's baby, they have the flat axe support, which you're probably already familiar with, the macroglossia, you're probably familiar with, the low set ears, you're probably already familiar with. Let me remind you of a couple of them that I know sometimes you forget about. The simian crease, they have one line on their hands, literally one line. You and I have an M. You see in the picture here, they have one line. That's called the simian crease. They also have a space between their great toe and their next toe. Okay, so that's another deviation. So a lot of it you're already familiar with, but pay attention to the other findings. Okay, they don't drill you too much on this. You know, the older you are, the more at risk you are of having a Downs baby. Okay, sometimes they have some cardiac issues. Okay, myasthenia gravis is special. Myasthenia gravis is on your NCLEX, and this one is a little bit complicated. So what's happening with myasthenia gravis? This is an autosomal or autoimmune attack. Okay, not autosomal, autoimmune. So autoimmune means your body is attacking itself. What is it attacking? It's attacking acetylcholine. What is acetylcholine? You need the right amount of that neurotransmitter in order to pick up a cup and put it to your face, in order to, you know, for your voluntary muscles. That's the receptor that sends messages. Okay, so without the right amount, you're gonna have weakness. You're gonna feel very exhausted. Okay, so it's a disease that is characterized by progressive weakness and exhaustibility of your voluntary muscles. Okay, that's a horrible one. So now, what's complicated about MG, myasthenia gravis, is that it's diagnosed in a special way, and then you also want to monitor crises. Okay, so patients could go into crisis with this. So also, I don't want to forget, spend time with the findings. You know which muscles are voluntary, but don't forget the drooping of the eye, like you see in the picture here, ptosis. Okay, diplopia, blurred vision, that's because those are voluntary muscles. Okay, right? Me blinking my eye, that's voluntary muscle. Okay, so you see here the little acetylcholine, which is the neurotransmitter that's being attacked. Okay, so the way we diagnose myasthenia gravis is with what we call the tensilon test. Okay, so the tensilon test, once you inject the client with the tensilon, they're going to all of a sudden get strong, literally right away. They gain their strength. That tells you they have myasthenia gravis. So we treat this, only 2 drugs you need to keep in mind for this, okay? Peridostigmine, Mestinon, and neostigmine, prostigmine. So those 2 drugs are what we use to treat myasthenia gravis. So the immunosuppressants, obviously, because it's an immune attack, so we could suppress your immune system, but those are not the drug to actually help with the cholinesterase. So now, this is where this gets complicated. So sometimes patient will go into a myasthenic crisis. Could be a number of reasons why they go in a myasthenic crisis, but we need to figure out what crisis they're in. Okay, is this a myasthenic crisis or is this a cholinergic crisis? Okay, so they could go into this too much, not enough of the drug, stress, whatever. So very dangerous though. Why is it dangerous? Because of a risk of laryngospasm. The patient's airway could close down. Okay, so that's why we care about this disorder. That's why it's so special too. So the way you differentiate between the 2, you need to give another injection, okay, of the tensilon. Okay, so once you inject the client with the tensilon again, you want to see if you have a positive or negative result. Positive test means myasthenia gravis. You're going to treat that with increase of the drug. Negative test indicates a cholinergic crisis, and we treat cholinergic crisis with atropine. Okay, so have that at the bedside, and I have a little table for you to compare cholinergic versus myasthenic crisis. Okay, this one is special. Okay. All right, stroke. I think I have time to cover stroke. Now, stroke is special. Why? Number of reasons. First of all, you know, if you have a right hemispheric stroke, left side is impaired. Left hemispheric stroke, right side is impaired. So now TIA is a mini stroke, just like an angina was, you know, partial occlusion, MI is a full occlusion. So similar analogy here. Now, there are different types of stroke. So before you even answer that question, take a look at what type of stroke you're dealing with. There's ischemic, or AKA also called occlusive stroke, which is very different from a hemorrhagic stroke. Do not start treatment until you know what stroke you're dealing with, okay? Because they are treated so differently. And if you mistreat, you could kill the client. Okay, so ischemic stroke is also called an occlusive stroke. That is a blockage. That blood clot, you have a blockage. Whereas a hemorrhagic stroke, the client is bleeding out. There is perforation, they're bleeding out. Okay, so you see how there's 2 different types of stroke. So NCLEX question, before you treat the stroke, rule out hemorrhagic stroke. Okay, because generally, if it's a clot, we're going to bring out the TPAs that we talked about earlier, the activate, we're going to bring out the clot busters. But if you ever use a clot buster on a hemorrhagic stroke, you kill the client. Okay, so for occlusive ischemic stroke, you're going to use the TPAs, the anticoagulants, the Coumadin and the warfarin that we talked about earlier, heparin, right? You're going to use the antiplatelets that we've already talked about, Plavix, absolutely. Dexamethasone, the steroids, we're going to decrease that edema. Okay, so that's for occlusive stroke. Hemorrhagic, we're going to focus on lowering your blood pressure. Okay, the antihypertensives, we can give the dexamethasone, that's going to help decrease edema. Mannitol is going to help get rid of all that excess fluid that's in your brain. That's a diuretic for that. Okay, you see how here we're using the antidote to clot busters. Remember we went over the antidote for your clot busters? Did we say Amilcar? Aminocopric acid is your antidote. We're using the antidote here. We would never use the clot busters. I think everybody's good with that. Don't miss that NCLEX question, okay? So we want to also decrease pressure in the head of this client. So try and keep the head of the bed, you know, not too high because that increases pressure. By the way, folks, there are so many things that increases intracranial pressure, okay? I have a whole list for you. Where's my list? Okay, it starts here. No Trendelenburg, right? Duh. Don't flex the hip. Don't cough. Don't sneeze. Don't laugh. All of these things increase pressure in your head. Okay, so all of these strenuous activities increases ICP. We don't want to increase ICP. Okay, that will just end up causing more of a problem whenever you increase pressure. So let's talk about trauma. I want to go to trauma to the spine. Okay, so now I mentioned to you earlier, you do need to know the different levels of the spinal cord because there are questions about spinal injury. So here's a couple of NCLEX questions. With these type of injury, you have neurological effect, you have cardiovascular effect, you have respiratory, musculoskeletal. So let's pull the NCLEX stuff out of this. Anytime you have an injury at the C3 or above, you're gonna need to be on a ventilator because you'll no longer be able to do this. No. Okay, so breathing difficulties from that paralysis of the breathing center and the nephrotic nerve is related to C3 or above injuries. And this client will be a quadriplegic where the arms and the legs will no longer work. If it's around the T, then they may be a paraplegic where their arms will work, but their bottom half will not work, okay? So whenever you have a patient with paraplegia, you can teach them, you know, to empty their bladder because if not, they're at risk of something called autonomic dysreflexia. That is on your NCLEX. Let's go over it. Autonomic dysreflexia is a dangerous, okay, condition where the client develop this from spinal cord injury that causes uncontrolled hypertension. Let me go over the process with you. So I love this. When I saw this by New Zealand, I was like, oh, perfect. I love when I find charts that just does such a wonderful job of explaining it. So we want to teach the client to empty their bladder and keep it empty and irregular because what happens is if there's a blockage, you know, from emptying the bladder, that urine in the bladder causes a distension, okay? That distension stretches the bladder, which sends impulses to the spine, okay? Those impulses, when they reach around the T, the thoracic cavity, the symptoms of the symptomatic neurons become activated, okay? It's like a domino effect. And those release norepinephrine. What does norepinephrine do? Raises your blood pressure. Okay, so we don't ever want, you know, the bladder extending like that. That domino effect that you see here starts, okay, that increased blood pressure could be very deadly. So we want to teach them to do that. And whenever you're dealing with these type of surgeries, there's management that we call emergency care, which would be your airway, breathing, circulation, right? In addition to the ABC at the acute emergency phase, don't forget, we do the C-collar because after airway, breathing, circulation, the spine is your priority for these type of injury. So do the C-collar. We don't want you moving and flexing the spine. And also do the backboard. We want you to be on a hard surface. And we even do something you call log rolling where we roll you all together. We don't want to roll top and leave bottom, okay? Okay, so you're good with that. And then long-term treatment will be more like the therapy, okay, depending on the severity of the injury. That's long-term care with the physical therapy, occupational therapy. We talked about elimination, teaching them to self-catheterize. So we want to prevent autonomic dysreflexia. Okay, so now let's talk about Glasgow Coma Scale. So Glasgow Coma Scale assess 3 areas: eye-opening, verbal response, and motor response. NCLEX. A patient is in a coma if their Glasgow Coma Scale is 9 or below. Okay, so we want above 9. All right, so a person ranging from 3 to 8 is in a coma. Okay, so below 9 is your cutoff mark. 9. Below that, you're in a coma. You can take some time to go over these charts. They're just different ones for you. Some of you think one way and some of you think another. One more thing I want to point out is these 2 vocabulary words: decerebrate versus decorticate. So the word core is body. So when you're going towards the body, that's decorticate. You see here in the bottom picture, the arms are going towards the body, the knees going towards the body, the foot towards. So when you're going towards the body, core means body. It's another root word for body. So decorticate, towards the body, and decerebrate is away from the body. So this happens a lot before folks pass away. There we go. Yes, you can see it. So reconnect for me if you're not able to see the endocrine PowerPoint. So let's talk about the endocrine system. The endocrine system works together with the neurological system. Okay, remember I told you all of the systems are connected. Don't ever think of them separate. Okay, their goal, their purpose is to function as the communicating system. Okay, so they secrete hormones, and without the right amount of these hormones, we would not function properly. Okay, so your endocrine glands, there's quite a few of them. Okay, they secrete chemical substance known as hormones. We need the right amount of hormones. Too much is not good. Not enough is not good. So endocrine is not a difficult, heavy system because it's one of those systems where if you know one, you know the other because it's opposite. Okay, so keep that in mind. The other thing you need to remember about the endocrine system, or when you get an endocrine question, always pay attention. Are you pre-treatment or post-treatment? Is this pre-surgery or post-surgery? You're going to see why that's important and why that makes sense in a moment. So what is the purpose of the endocrine system? It's involved in our reproductive system. Metabolism is a big one with the thyroid. We're going to talk about that. Growth. Folks end up a giant or dwarf based on the amount of hormones being released by the pituitary. Our electrolytes, okay, balance, our in our bloodstream. For example, we talked about the electrolytes a couple of sessions ago in reference to how the adrenal gland, balances. We talked about salt, water following salt. So that also, the endocrine system also plays a role in that, in regulating that balance, and deals with the adrenal gland big time. We're going to talk about the adrenal gland and some tumors with the adrenal gland. We're going to talk about epinephrine and balancing some of the other electrolytes because that's part of the endocrine system job. So let's go over some of the glands. First, I'm going to go over where they are, what their jobs are, what hormones they're responsible for secreting, and then we'll go over what happens when it secretes too much of that hormone or not enough of that hormone, okay? So the first one I want to cover is the pituitary. The pituitary is in the brain, as you can see in this picture here. It's in the brain. The thing with the pituitary, it has an interior, a front, and it has a posterior, a back. So the front secretes its own set of hormones, the back secretes its own set of hormones. So if you see here where it says anterior lobe, these are the hormones that the front of the pituitary secretes. Now the pituitary doesn't directly deal with each of these areas. What happens is the pituitary is a master gland. So the pituitary controls these other glands that actually release these hormones. So what do I mean by that? So you see here how the interior pituitary controls ACTH. That's not physically with the pituitary, that is with the adrenal glands on top of the kidneys. FSH, growth hormone, luteinizing hormone. One of the most important ones is TSH, the thyroid stimulating hormone. So you could have an issue with your pituitary, but it's showing up in your thyroid or vice versa. So the pituitary is a master gland. It controls all of these other glands, okay? So too much of these hormones are not good. Too much of these hormones, for example, too much of a hormone being secreted by the anterior pituitary will affect your growth. Those are the folks who end up looking like a giant, and vice versa. Not enough, they have dwarfism. The back of the pituitary secretes its own set of hormones. One of them we've already spoken about. When we did OB, health promotion, we talked about Pitocin, oxytocin with the pregnant woman going into labor. That is produced in the back of the pituitary naturally when it's time. So we're not going to talk about this one today. We're going to talk about ADH, antidiuretic hormone, which too much of it is not good, not enough of it is not good. And the conditions are diabetes insipidus and SIADH, which we're going to cover in a moment. So again, the pituitary is a master gland. It controls other glands. The front secretes its own set of hormones. The back secretes its own set of hormones. The anterior pituitary, when it's not secreting enough hormones, is hypopituitarism. And vice versa, too much is hyperpituitarism, okay? Now, the next organ we're going to talk about, oh, by the way, those of you who are visual learners, this is a nice picture of the anterior versus the posterior pituitary. You see here how the front with the adrenal gland I was talking about, and look at a beautiful picture of the thyroid here. And you see the back when we talked about OB with oxytocin, pitocin, and today we're going to talk about antidiuretic hormone with the kidneys. How much urine do we put out? So that's coming up. The next gland I want to talk about is the thyroid gland. So the thyroid gland sits in the neck, right? You assess it from the back, okay? You're feeling for any lumps, bumps, goiters, any tenderness, okay? The job of the thyroid is to control 3 hormones, T3, T4, and thyrocalcitonin. What do these hormones do? What's their job? Their job is to metabolize. Everything we eat and put in our mouth has to be broken down and metabolized and go into our cells and give us energy. The thyroid handles that. So imagine that's overworking or underworking. We have a problem. So we're going to talk about hypopituitarism, which is also called Hashimoto disease, and we're going to talk about hyperthyroidism, which is called Graves' disease. They're both bad. And then we're also going to talk about a little something called the negative feedback with the thyroid in the pituitary, okay? I'll cover that when I cover the labs. It just makes a lot more sense during that time. So another thing I want you to remember about the thyroid is that in order for your thyroid to function properly, you need the right amount of iodine in your diet. Okay, so iodine is essential in your diet for the synthesis of your thyroid hormone, okay? There are some times where even before surgery, physicians will do an injection of iodine right in the thyroid to shrink it before a thyroidectomy. Okay, so keep in mind the little iodine thing with the thyroid, okay? That's an NCLEX question. All right, now let's talk about the parathyroid. Okay, the parathyroid sits on top of the thyroid. They're important as well. Their job is to control 2 electrolytes, calcium and phosphorus. That is their job. And calcium and phosphorus do a seesaw thing. So we're going to talk about hyperparathyroidism, and we're going to talk about hypoparathyroidism. Okay, very, very important, those 2 electrolytes. You need the right amount of calcium floating through your bloodstream. You need the right amount of phosphorus. So your parathyroids handle that. Now imagine a patient who had a thyroidectomy. If you remove the thyroid, you also remove the parathyroids. And hypocalcemia is extremely dangerous. Hypocalcemia causes laryngospasm, which now deals with airway, which now prioritizes this client. We'll talk about that in a moment, okay? The next gland I want to talk about is the adrenal gland. If you have 2 kidneys, you have 2 adrenal glands. They sit on top of the kidneys. Now, they have an outer hard cortex shell and they have a soft inner medulla. The thing is, the outer cortex secretes its own set of hormones and the inner medulla secretes its own set of hormones, which we're like, great, right? More stuff to remember, but that's just the way it is. So the adrenal glands that sits on top of the kidneys, the outer cortex secretes 3 hormones that you need to be familiar with, okay? We have a little name for them. There's a little mnemonic. We say the 3 S's. Okay, I'm gonna come back to this picture. So the 3 S's, glucocorticoids is sugar, that's S number 1. Mineral corticoids, that's steroid, that's salt, S number 2. Androgen, sex hormone, that's S number 3. So the outer cortex that sits on top of the kidney, the adrenal gland, the outer part of the adrenal gland is the cortex. It secretes 3 hormones: glucocorticoids, mineralocorticoids, androgen, which we call the 3 S's: sugar, salt, sex hormones, okay? So now you know we can't live without balancing these hormones. You don't want too much salt flowing through your bloodstream. You don't want too much sugar, okay, or sex hormones. We need a balance. We need homeostasis, okay? Remember, it's the kidney's job to balance that and cause that homeostasis the right amount. We have too much, it excretes it. We don't have enough, it holds on to it. We're going to talk about renal failure soon, but we need homeostasis, okay? So that is the outer cortex. Too much is not good. Not enough is not good. We're going to talk about Addison's disease, okay, where you don't have enough of these hormones being produced. We're going to talk about Cushing's syndrome, where you have too much of these steroids being produced, okay? On the inside of the adrenal gland, you have the inner medulla, the soft part, that secretes its own hormones. It's responsible for epinephrine and norepinephrine secretion, which, remember, is part of your sympathetic nervous system. There's only one condition with the inner medulla that NCLEX questions you about, that you need to know about, is the pheochromocytoma disorder. That is only caused by a tumor that grows on the inside of the adrenal gland. So once you have a tumor growing on the inside of the adrenal gland, that condition is called pheochromocytoma, which is a non-cancerous tumor, but it is still very dangerous. We'll go over that condition in a moment, okay? So now, the pancreas is also an important part of this section for endocrine. Your pancreas is responsible for secreting insulin. If your pancreas is not secreting insulin, you cannot get the sugar from your food to get into your cells to get energy, and that's a problem. So we're going to talk about type 1 versus type 2 diabetes. We're going to talk about insulin and oral diabetic agents. Okay, that's probably one of the most important parts of endocrine, okay, is when we get to diabetes, because the chances of you encountering a diabetic client is very high. The chances of you encountering a hypertensive client, like we talked about last session, is very high. So the conditions where you're most likely to encounter these clients, no matter what specialty you go into, are the most important ones. Rarely you will encounter a pheochromocytoma client. You know what I'm saying? But you probably will encounter a diabetic, okay? Right? It just makes sense because it's such a, prevalent disorder. So here's a nice, beautiful picture of the pancreas here. Okay, I love this picture. You can even see the pancreatic isolates, and it gives you even, some pathophysiological breakdown. You can see the common bile duct here beautifully. I really like this picture. Don't even remember where I got it from. So very nice. We're going to talk about type 1 and type 2 diabetes. The next few slides are diagnostic tests. So most of what we're talking about are blood work, okay? And most of them, as you go through them, you'll see no special prep, no special prep, no special prep. They're blood work. There are a few of them you need to be NPO for, but not most of them, there's no special prep. So you just need to be familiar on how these are just blood work, and that's how we diagnose some of the conditions we're going to talk about. There is one diagnostic test I'm going to break down a little bit later, and that's the hemoglobin A1C. Okay, HbA1c, okay? I will break that down in a minute. And by the way, the other name for capital H, little b, capital A, 1, little c, is glycated hemoglobin. You need to keep that in mind because you may not see it the way you're so used to seeing it with the capital H. Students have told me they have the word glycated hemoglobin on their NCLEX. So please know that that is hemoglobin A1c. I'm going to talk about that test because there is a nice NCLEX question with that test when we do diabetes. There is no special prep for it, but there are a couple of NCLEX questions in reference to the percent, whether the client is a diabetic or not a diabetic. But the rest of them are blood work with no special prep, okay? You can take a look at them when you get a moment. All right, so now let's start with the disorders. Hyper and hypopituitarism is not as common as the others, so I have to jump around. So I'm gonna jump to the posterior pituitary. Okay, the posterior pituitary, you're most likely to get those questions. So with the posterior pituitary, so remember, that is the back of the pituitary that produces antidiuretic hormone, ADH. So let's go over what is antidiuretic hormone. So this hormone, its job is to control urine output. So first of all, you need to commit to memory your normal urine output. Your homeostasis normal urine output should be between 30 to 60 mLs per hour. That's your range, okay? And don't forget the little analogy, what goes in must come out, okay? Whatever you put in needs to come out, right? But your normal range for urine output is 30 to 60 mLs per hour. You memorize that. If you didn't, you will. So now, the job of ADH is to control how much urine you put out per hour. We need the right amount. We need homeostasis. So when you have a problem, maybe a tumor, trauma, something happened to the back of the pituitary gland where you're not making enough antidiuretic hormone ADH, now this is where the patient will just urinate nonstop. Okay, they have too much urea, polyuria. So that is a problem. They're going to become dehydrated in a moment, right? It's happening at night, nocturia, and they're going to get constipated because you're just peeing. Too much diuresis. So you know we're going to need some antidiuretics. That's coming up. The moment I tell you the problem, you have to think of the solution. This is a diuretic issue. Diuresis is happening, so we need anti. But your other problem, and you need to keep this in mind too, there's an NCLEX question about the urine-specific gravity. You also need to memorize your normal urine-specific gravity. It's on your list of NCLEX lab values that you need to memorize. So the normal urine-specific gravity is 1.010 to 1.030. One more time, the normal urine-specific gravity, which you will memorize, is 1.010 to 1.030. So if you see here a diabetes insipidus client, their urine is going to be very diluted because here it's 1.006, so that's below. Okay, so their urine is very diluted. So keep that in mind. Also, do not ever mix diabetes insipidus with diabetes mellitus. They're not even in the same family. They have similar names, but not even the same organ, nothing. One is dealing with the pituitary, posterior pituitary too, and the other one is dealing with the pancreas. Nothing to do with one another. So never mix diabetes insipidus with diabetes mellitus. Nothing to do with one another, okay? So now, an extra diagnostic test we do for diabetes insipidus is called water deprivation test. What is that? Water deprivation is where we literally deprive the client of water. You and I, we do not have diabetes insipidus. We don't have any head injury, nothing. If we don't drink enough water, our urine is going to be very concentrated. So this client, that's not the case. So the client with diabetes insipidus, their urine is going to still be very diluted. So physicians will do this because they want to differentiate whether this is a primary, pituitary diabetes insipidus or if this is a renal nephrogenic problem. Okay, so we differentiate between the two by doing a water deprivation, and you'll also do the CT scan and all of that to see what's going on with the pituitary. So now let's talk about medication. So we do need antidiuretics. We don't want this patient peeing themselves to death. So desmopressin, vasopressin, they're going to be part of the regimen. And you're also going to give IV fluid. If they don't have any nausea or vomiting, we can give PO and IV. And if there's a tumor, they have to go to surgery and remove that tumor. Okay, there's usually no treatment for those. If there's a tumor, surgery is coming, okay? So because the pituitary is in the brain, always keep in mind increased intracranial pressure. Okay, there's a risk of that. So we want to monitor them for sign of ICP and also put measures in place to decrease ICP. So no bending at the hip, no coughing, sneezing, Valsalva, all of that stuff increase ICP. Okay, so I'm going to sound a little bit like a broken record because of repetition, because of the pituitary being in the brain. Okay, so the ICP, anything in the brain, you want to think about the increased intracranial pressure or possibility and also prevent it. Okay, so now, opposite. So we just talked about diabetes insipidus where you're not making enough ADH. So now let's talk about when you make too much ADH. Okay, so now you're making too much of this hormone. This prevents the client from urinating. So literally they're holding on to every fluid. That's a problem. Okay, so they become diluted. So this client will start having some mental changes, okay, changes in level of consciousness. They're going to be tachy. The heart is trying to compensate, the body's trying to compensate. But your biggest concern or your priority concern with SIADH, okay, syndrome of inappropriate antidiuretic hormone, is the hyponatremia that happens. So imagine you have a cup of water, a glass of water. I happen to have one right here. Imagine you have a glass of water and you keep adding water, adding water, adding water, adding water without adding any electrolytes. Okay, and then you're not able to, the kidney is not able to filter and get rid of that excess water and keep the sodium that it needs. So this client ends up internally hyponatremic. That is your biggest concern. You need to fix that hyponatremia. So even though they're holding on to every fluid, you will give fluid. That is one of the treatments. Why are you giving fluid? Because you need to fix that electrolyte imbalance. But you're also going to give diuretics because we do need them to pee. So diuretics is part of the regimen, but you want to also give hypertonic solution. So that fluid, that IV fluid you're going to give them will be very high in sodium because of that hyponatremia that they have. That's the NCLEX question, folks. So please don't miss it, okay? All right, so now we're done with the pituitary. Let's do thyroid. Okay, so with the thyroid, hypothyroidism versus hyperthyroidism, in other words, Hashimoto versus Graves' disease. Okay, you remember these two little mnemonics. They're all over the place. Whoever drew these did a wonderful job. Kudos to them, okay? So let's do hypo first, and then we'll do hyper. So hypothyroidism, or AKA Hashimoto. So what's happening with these clients, they have a decreased amount of the thyroid hormone. But remember the job of the thyroid hormone, T3, T4, and thyrocalcitonin, right? Which helps metabolize. So everything we eat have to be broken down and get into our cells. Now, these clients are not making enough of this hormone. Okay, so, and also don't think of this being an old people disease. It's not, okay? So, but it is a very dangerous one. If this is happening in children, it could lead to mental retardation. If it's a pregnant woman, it could lead to the child being, born with some neurological deficits. Big problem. As this disease progresses, the patient ends up in what we call a myxedema coma. Now, everything I'm saying now, you're going to hear me say opposite for hyper. And that's why I tell you endocrine is not difficult. Once you know one, you know the other. So hypo, they end up in a coma. Hyper, they go crazy. Okay? Psychosis. You see how opposite? So hypothyroidism, you're not making enough of the hormone to metabolize the food that you eat. You end up in a myxedema coma. Hyperthyroidism, you end up with psychosis. So I'm going to go ahead and cover them together by showing you the opposite, okay? So now we're talking hypo. They are the ones who are hypothermic. They're always cold. You see the little mnemonic there? They're always cold. Hypo, Hashimoto, always cold. Hyper, opposite, they're always hot. Okay? Brady, let's do the Brady. Big difference as well. Hypo, bradycardic. Hyper, tachy. Okay? Hypo, hypoventilating. Hyper. You see what I'm saying? They're all opposite. And even with the level of consciousness, Hashimoto, coma. Hyper, Graves' disease, crazy, right? That is all opposite. So what I want to tell you also with this area, endocrine, you need to also spend time on the finding, because you may get an NCLEX question that tell you the patient has Hashimoto, the patient has Graves' disease, the patient is hypo, or they might describe it, or they might give you lab values. So you need to be able to tell that they've described a hypothyroid client or a hyperthyroid client. Don't just relay, because at that level, that's a level 3, level 4, when I can describe the condition and you know what condition I'm talking about. You see what I'm saying? So you need to spend time with the finding where, okay, this is the client with the intolerance to cold, with the bradycardia. You see what I'm saying? You have to do that. Don't just rely on them always telling you this is this type of client that you have, because then you're at the lower level of this test. Okay, let's talk about the lab, the diagnostic test, and also the negative feedback that I mentioned earlier. So we're talking hypothyroidism. So whenever the thyroid hormones are low, like your T3, T4, okay, are low, they're decreased, your body will try to compensate. The hormone, the gland that's coming to compensate will be the pituitary. Remember, it's the master gland. It controls this gland. So whenever your T3, T4 is low, your TSH, thyroid stimulating hormone that is coming from the pituitary, that will always be high because it's going to try and fix the problem. That's the negative feedback. So always associate the disorder with the T3, T4. So your hypothyroidism, your T3, T4 is going to be low, but your TSH is always going to be opposite. So now let's do hyper. So your hyperthyroidism, your T3, T4 is going to be high, your TSH is going to be opposite, which is low. So one more time, that is called a negative feedback. So your thyroid, whatever it is that it's doing, your TSH is going to be doing opposite. So if your hypothyroidism, your T3, T4 are low, your TSH is going to be high. Vice versa. If your T3, T4 are high, your TSH is going to be low. Okay? That's the negative feedback. It's trying to compensate. All right, so now let's treat these disorders. So we're talking about hypo, you don't have enough. So the treatment is to give it. So we're going to give you the synthetic made in the lab, okay, drugs to replace the hormone that your gland is not making enough of. So levothyroxine, okay, Levothyroid, Synthroid, Cytomel, those are your drug of choice to treat hypothyroidism. Now, these drugs are little high maintenance, okay? So your thyroid medications are always given in the morning on an empty stomach. Please keep that in mind. In addition to that, never mix them with other vitamins, milk product or stuff like that. Give them apart from those things. Always in the morning on an empty stomach. The other thing too, your thyroid medications do not mix well with Coumadin, warfarin, which we've already talked about, or insulin. So you need to do a medication reconciliation for this client. I need to know what else you're on. So your thyroid medication enhances Coumadin. So this client is going to be at risk to bleed. Your thyroid medication decrease the effect of insulin. They're going to be at risk of hyperglycemia if you mix these drugs with thyroid hormones. So keep that in mind. So your thyroid medications require a little teaching, okay? All right, so that was hypo. Now here's hyper. You're gonna hear me say the opposite. I kind of covered them together. So the other name for hyperthyroidism is Graves' disease. The patient could go into thyrotoxicosis, where they go into a schizophrenic behavior, okay, or psychotic behavior where they're hallucinating, that they go crazy. Yep, I mean, they have psychosis. So you see very opposite of what we've talked about. In addition to the opposite with the coma versus the psychosis, the other thing I want you to keep in mind, for hyperthyroidism, a lot of times they have cardiac issues too. Angina, infarction, heart failure. So keep that in mind, but that doesn't happen with hypo, it's with hyper. Okay, and don't forget you need to spend time with the finding in hyper. Okay, by the way, the goiter could be both with hypo or hyper. It's not necessarily always hyper. Okay, so folks assume that the goiter only comes with hyper. No, you could have the enlarged the goiter and then you have hypothyroidism. Okay, so that's a little difference with those two. So don't forget the hyper, they're the heat intolerance, they're the one with the bulging of the eye, which is called exophthalmos. They're tacky, not Brady. Okay, they palpitate. So you do need to spend time with the findings. Okay, we already talked about the TSH and the T3, T4 lab values. So now let's talk about treatment. You're making too much. So I need to suppress you from making it. And the drugs are PTU, okay? Sodium 131 or profylthiouracil are great, PTU, okay? And also, we also talked about propranolol and Inderal in the past. We would be using it here for the hypertension because it's a beta blocker. So you see how the others we're treating signs and symptoms. Don't forget the iodine. Okay, so an injection of that iodine would be used to decrease the vascularity. That would be before surgery. Okay, physicians will do that. So now let's imagine the client needs to have a thyroidectomy. Okay, so ectomy means removal of. So you're going to treat them like a post-op client, but we're going to talk about the parathyroids with that, because once you remove the thyroid, the hyper and hypothyroidism is not your biggest concern. It is a concern, but it is not your biggest concern. Once you remove the thyroid, your biggest concern is the calcium. We're going to talk about that in a moment, okay? And you see here about the intracranial pressure. If it's a pituitary problem, you end up removing the pituitary, and it's not really, because sometimes you could have it and it's not a thyroid issue. Remember, the pituitary is the master gland. But if you end up having a thyroidectomy, your priority is hypocalcemia. That's coming up. Okay, so this is a comparison of the two of them. You can spend time with that. Just have some pictures for you of the exophthalmos and the dwarfism. That would be with hypopituitarism. All right, now let's talk about the parathyroid. It's very important gland. So they sit on top of the thyroid. So if you remove the thyroid, I'm assuming everybody can hear now, right? Because I checked it. Yes, you can hear me. Okay, I'm always afraid of that. So that's why I always have another screen here that's like your screen, so I can see what you see in case there's a technical difficulty. I will be able to tell. So I'm on another screen as if I'm a student, so I can see what you see and hear what you hear. So if there's ever a problem, I'm able to tell. And I'm doing okay here. I can see me, I can hear me, I can, okay. All right, back to the parathyroids. So they sit on top of the thyroid. So if you remove the thyroid, you remove them as well, okay? So hypoparathyroid, too little, not enough. Parathyroid, and parathyroids control calcium and phosphorus. And calcium and phosphorus do a seesaw thing. I'm gonna show you the seesaw. They're never up together, they're never down together. When one is up, the other one's down. So now, what happens when you don't have enough calcium? How do you look? How does this patient present? Okay, so here are the findings here. The crimping, okay, the muscle weakness, like a myasthenia gravis client. They get the numbness and tingling of the fingers and toes, tetany, carpal tunnel spasm. The biggest problem here is not the seizure, it's the laryngospasm. Laryngospasm deals with airway. We covered that when we covered croup, very dangerous. So that is our priority. That is why hypoparathyroid or hypocalcemia is a priority, because of the risk of the airway shutting down. So you need to always assess these lab values. We're going to do a chem panel. We need to know what the serum calcium and phosphorus are, and you're memorizing these values. You've already memorized these values, okay? So now there are some specific tests to see if the patient is hypocalcemic, okay? So ShovTech and Trousseau's are on your NCLEX for sure. So these two diagnostic tests are specifically for hypocalcemia. I'm assessing to see if your calcium level is low. ShovTech starts with a C, so does the word cheek. Okay, so this is the one where you strike or tap the client's cheek, and if they're hypocalcemic, they will twitch. Trousseau is the one where you put the blood pressure cuff, and if they're hypocalcemic, they will spasm. Okay, they'll get all, you know, pumped up. So that's hypocalcemia. Or if they're positive, then it tells you the patient is hypocalcemic. You have to have an ampule of calcium at the bedside for these clients. So you keep it there literally. So if they're positive for these, you can administer them. Now, there's NCLEX question about this condition that deals with the diet. So if you're hypopara, that means you're low in your calcium. Your diet should be high in calcium, but low in phosphorus, and vice versa. The client who is hyperpara, their diet should be low in calcium and high in phosphorus, okay? So opposite, and that's why I keep telling you, know one, you know the other, okay? So now let's do hyperpara. So hyperpara, now your calcium is too high and your phosphorus is not enough, is not high enough. So now these clients that are high in their calcium level are at risk for stones. Okay, so hypercalcemia puts you at risk for stones, kidney stones, gallstones, stones. So very painful. These clients moan, groan because there's stones in their bones. Very painful condition. So you want to treat that, you know, with the stones. We want to filter it. We may do little Tripsy to break down the stones, but that's their risk factor because of that high calcium level. Okay, so once you pull a chem panel, you will see that the calcium is elevated, but the phosphorus is low, and that also tells you the diet. Okay, so if they have, now the other thing you need to remember with endocrine system, remember earlier I tell you, pay attention, are you before treatment or after treatment? If you are before treatment, you're dealing with the current condition. If you are after treatment or after surgery, expect the opposite. The client is hyperparathyroidism and you have a thyroidectomy, you're not at risk of hypopara. I'm hoping that makes sense. We're going to talk about the adrenal gland, same thing. So you have a tumor growing on there and you have excess epi and norepinephrine, your blood pressure is high. So now we remove, let's say we remove both adrenal glands. You're now at risk of hypo, okay? We're going to talk about Cushing's and Addison's in one moment. All right, so there it is. Let's talk about the adrenal gland. So the adrenal gland, again, sits on top of each kidney. There's an outer cortex and an inner medulla. Okay, you see here the outer cortex secretes aldosterone and corticosterone. Okay, very important for us for our blood pressure. Okay, and the inside of the medulla secretes epi and norepinephrine, your catecholamines. Okay, so the outer deals with your mineralocorticoids, your glucocorticoids, your steroids, and the inner deals with your sympathetic nervous system, your epinephrine and your norepinephrine. Okay, so let's go over that. Too much of the steroids, okay, adrenocorticotropic hormone, your ACTH, okay, your adrenocorticotropic hormones control those three S's we talked about, okay? Remember salt, sex, and sugar. Mineral is the salt, gluco is the sugar, the sex hormone, the androgen. So the outside of the adrenal gland controls or secretes. So here's a condition where they're not doing that. It's not secreting enough of those three hormones. So if salt is one of them, you're gonna be hyponatremic. If sugar is one of them, which it is, you're going to be hypoglycemic, okay? So now that you know what's being secreted, you know electrolyte-wise. Remember I told you earlier, we're going to talk about the electrolyte component of the adrenal system. So now, let's talk about the finding. So this is something I see we underestimate, because you expect the test to tell you, oh, you have an Addison's disease client, you have a Cushing's disease. They don't always do that. They'll describe these clients. And don't forget, in addition to all that you see here with the confusion, the hypotension and all of that, Addison's is the one with the skin changes, okay? Not Cushing's. Addison's is the one with the pigmentation. They get bronzy. You hear that term, you see that term in your NCLEX question. They get bronzy, like in this picture here. So keep that in mind. That happens with Addison's, not Cushing's, okay? So I love this little mnemonic, okay? They're the ones with the weight loss, increased sodium, decreased sodium, but increased potassium, because remember the seesaw, the sodium potassium pump. So these little mnemonics really help, okay? They're gonna be hypoglycemic, hyponatremic, which explains the hypotension, okay? So diagnostic wise, we're gonna do the ACTH, okay? The cortisol level is gonna be low because we're talking Addison, we're talking low, okay? You do a 24-hour urine collection, the cortisol is low. So how do we treat that? You're not making enough. We are going to give you the synthetic form. So the treatment for Addison's, okay, is hydrocortisone, Cortef. That will replace the glucose that you're missing. The other treatment is fludrocortisone, the mineral, the salt, that will replace the salt that your body no longer is making. Now, another NCLEX question you need to keep in mind for all of these conditions that we're talking about, the thyroid, the adrenal gland, the pancreas coming up, these treatments are for life. They're not for a month or two, they're forever. It's really, you gotta process that, you know, I hate to be on something for life. The other thing I want to point out for all of these conditions is you don't ever want to stress these clients. The moment you stress them, you aggravate the disorder. Okay, so you always want to reduce stressors, manage stress, decrease noise, turn up the TV, get people out of the room. Don't stress this client. You stress them and then you end up, you know, with the disease aggravated. Instead of helping this client, you make them worse. Okay, so keep that in mind, no stressing them. All right, opposite now, Cushing's. You're making too much of all of these hormones, too much mineralocorticoids, too much glucocorticoids. You're going to be hypernatremic, so that's going to cause hypertension. You're going to be hyperglycemic. Your blood sugar is going to go high. Okay, so those are your Cushing syndrome client, too much cortisol. You do the ACTH is high. You do a 24-hour urine collection, the cortisol is high. So know how these clients present. They're hypertensive, they're metabolic alkalosis, okay, because they're at risk of diabetic ketoacidosis. They act like a diabetic because of all that excess sugar. The pancreas cannot keep up. They're hyperglycemia. So watch them for that. They're the ones with the moon face and the buffalo hump and all of that. Nice picture, okay, that I have here for you. So know what they look like, okay? How do they present? So management, you're making too much, or sometimes, a lot of time, this condition, you know, it's a tumor. So the tumor needs to be removed, okay? So once the tumor is removed, you're back to Addison's, okay? You don't have that gland anymore to be making this hormone. So keep that in mind. Are you pre-treatment or post-treatment? And for Cushing's, they're going to be on a very specific diet as well. So with this condition, they're hypernatremic and hypokalemic. So you know just from me telling you that what their diet is going to be like. If they're already hypernatremic, their sodium is already high, so they need to be on a low sodium diet, okay? But high potassium diet. So you may be given these questions where you have to pick a tray for these clients. That's why you need to have the breakdown of what the labs look like. That will tell you what type of diet and tray to choose for them, okay? All right, so nursing intervention, monitor for the hyper and hypo with the electrolytes, okay? And again, these treatments are forever. It's not a month or two, forever, which is crazy to think having to be on something lifelong. All right, now that was the outside of the adrenal gland. Now the inside, pheochromocytoma. So this is due to a tumor growing on the inside of the adrenal gland. So that causes a release of epi and norepinephrine. Okay, without a tumor, our adrenal gland releases the right amount when we need it. Okay, but with this tumor, it's releasing too much, very fatal. So let's go to NCLEX. When you have a release of catecholamines, okay, which is your epi and norepi together, you are at risk of a hypertensive crisis. Your fight and flight, your sympathetic nervous system is activated, but it's out of control. So you're going to be hypertensive, headache, tachycardia, the body's trying to compensate. So our job as the healthcare provider is to keep your blood pressure under control. So what you need at the bedside, your golden treatment, your drug of choice for the hypertensive crisis is phentylamine, okay, Regitine. You need that at the bedside. The moment you see that blood pressure, getting ridiculous, you need to give and administer that phentylamine. So that is your drug of choice, okay? Another NCLEX question with pheochromocytoma is about palpating, or rather not palpating the abdomen. It is imperative that you have that at the bedside, you have that on the patient's chart, you have that everywhere. Do not palpate abdomen. Why? Because when you palpate this client's abdomen, you're releasing epi and norepinephrine. They will go into a hypertensive crisis. So again, client with pheochromocytoma, tumor in the inside of the adrenal gland, do not palpate abdomen. Because when you palpate abdomen, you will release epi and norepinephrine, which will cause a hypertensive crisis. You better have that phentermine in hand. Okay, so if they end up having the adrenal glands removed, especially if you remove both of them, we're back to Addison's. No more outer cortex. You can't just get rid of the inside. Okay, so if they have an adrenalectomy, especially if it's a bilateral, both of them, adrenalectomy, Addison's is your condition that you need to be watching out for, because there's no more, they can't release anything. The organ is gone. Okay, so then they'll be on those for life. All right, the pancreas. Any questions so far? I'm sure everyone can hear me because I can hear myself on this side. So we're gonna go into diabetes. Very, very important topic. So if you haven't been, following me, please wake up. This is very important. Like I said earlier, the chances of you encountering a diabetic is more likely than a pheochromocytoma. Okay, it's true. So here's a beautiful picture of the pancreas. Let's go over the job of the pancreas, okay? So the pancreas, its job is to release insulin, okay? So we eat and eat and eat. We talked about this when we did basic care and comfort and reduction of risk. Everything we eat, when we did nutrition, we talk about it being broken down, okay, turning into sugar. That sugar is supposed to go into our cells to give us energy. It is the job of our pancreas to release the transporter called insulin to get that sugar into our cells. So now, when that doesn't happen, you end up with a condition called diabetes mellitus, which is a chronic condition where the pancreas produces either too little or not any insulin at all. So let's talk about type 1 versus type 2. So type 1 diabetes is when your pancreas does not produce insulin. Okay, you have a severe autoimmune, the body, okay, your pancreas itself is having the problem, autoimmune response. So you have a severe, some clients don't make insulin at all with type 1 diabetes. So that is very dangerous. How are you supposed to get all this sugar in your cells if there's no insulin to do so? So now, what's the difference between type 1 and type 2? So type 1, you don't make insulin. Type 2, you do make insulin. okay? But the insulin you're producing is fine. It picks up proteins, it picks up fat that you eat, but it does not pick up carbohydrate, okay? So one more time. Type 2, you make insulin. It is sufficient for protein and fat, not carbs, okay? So type 2 is also a product of or caused by lifestyle. So those who are overweight or have a sedentary lifestyle where there's no exercise and things like that, you are at risk. Okay, so obesity is a big factor of type 2 diabetes, okay? So that's the difference between the two. That is why we always treat type 1 with insulin. You have to treat type 1 with insulin. Whereas type 2, you could do insulin or oral diabetic agents. You have that option, okay? So I love these two little mnemonics because they kind of explain these two conditions. So with both conditions, by the way, you have the polys. Polyuria, too much urine, that's why they go to the bathroom frequently. Polydipsia, they're always thirsty. And I'm going to go over the pathophysiological breakdown to diabetic ketoacidosis so you can see why they pee all the time. They're always thirsty and they're always hungry, which is the polyphagia, okay? So this used to be called, as you know, insulin dependent. They keep changing the names on these things. And this one, type 1, is also the one that's more of a family, okay, familial tendency, meaning it runs in the family, okay? It runs in my family, but I'm adopted, so I don't have diabetes, but my adoptive mother does. Her sisters, I think about all of them do. My oldest sister, the third sister or fourth, it's a bunch of us. I'm the youngest of 10. My adoptive mom had 8 kids and she adopted myself and a cousin. So 10 of us grew up together. So I don't have diabetes, but the family line from my adoptive mom, yeah, a lot of them are diabetics. The sister right before me is also a diabetic. So that's definitely a familial, tendency in the family. So they should really be careful, but they're non-compliant, very non-compliant. The sister right before me, though, she has type 2. It's a lifestyle thing. Many years ago, I gained weight, and I'm one of those. Whenever I have a comfort weight, whenever I'm out of it, I know I can feel it because I can't breathe. So I gained weight. This was many years ago. I didn't even think I had Gabriel yet, and I wasn't feeling well. So I went to the doctor. Sure enough, my hemoglobin A1C, which I'm going to talk about in a moment, was borderline. I think it was like 6.5 or something like that. So the nurse practitioner says, you need to lose weight because you're borderline diabetic. And I'm like, ugh, can I get a pill, She's like, no, you need to lose weight. So I was like, crap. So went on a diet and lost weight, and I've been fine since. No diabetes, nothing. The sister right before me, who's a physician and knows better, same thing. She was borderline diabetic, but she loves to cook. I hate to cook. I can't cook for nothing. I think most of you already know that. So her cooking all the time, she ended up gaining weight instead of losing weight. So she's now on insulin. So you see, it was a lifestyle thing that caused both of us to be borderline diabetic, but I did the right thing in keeping my weight within, and I never needed to get on medication or insulin or anything like that. And she did the opposite. She's like, she loves to cook, and it's kind of hard when you're a cook, and she's very good at it too. Me, oh my God, even when I follow a recipe, it doesn't turn out right. But anyway, that's not NCLEX. So the NCLEX part deals with the lifestyle. The other thing with the diabetics that I'm going to talk about is wounds. Ugh, you don't ever want to see wounds on a diabetic, and that's an NCLEX question. So you know the difference now between type 1 and type 2, okay? Type 1 is the familial tendency one, runs in the family. Type 2 is due to sedentary lifestyle, okay? Obesity, no exercising, as you can see in the picture here. Okay, so now let's talk about diagnostic tests. So one of the tests we use to diagnose is called the GTT, which we talked about when we did OB, glucose tolerance test. Your glucose tolerance test is really, we're challenging the pancreas. So we have you drink, sugar, and we see what the pancreas is doing. We're gonna do your blood work to see if your blood sugar is within the normal range, if the pancreas did its job. But the other test we do for diabetics, that's on your NCLEX, is the hemoglobin A1C, or AKA glycated hemoglobin or glycosylated hemoglobin, same thing. Blood lives for 120 days. So when we do your blood work and we do a hemoglobin A1C from the blood that we collect, we're looking at the average blood sugar for the past 120 days. So if your blood sugar, 120 days, 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 120 days is averaging about 115, your hemoglobin A1C will be about 6%, as you can see in this picture here, the third green. So 6% is your hemoglobin A1C. That means your average blood sugar is 115. So now here's the NCLEX question. Pay attention. The patient, the client in your question, are they a non-diabetic or are they a diabetic? Because if they're not a diabetic, we expect their hemoglobin A1C to be less than 6. If they are a diabetic, less than 7. Because they're diabetic, we expect it to be abnormal. So if they're 7%, that means their average blood sugar has been around 150. The other thing you need to remember about diabetics, we don't mind if their blood sugar is consistently a little elevated. So let's say they run 130, 140 on a regular. That's fine. The problem is when they have that jump. Okay, so right now they're 130, later on they're 300. Okay, this morning you take it, they're 150, and then in the afternoon they're DKA. That's the problem we don't want, that jump, that inconsistency. But if they're consistently 140, 150, as long as they're consistent with that, they're a diabetic, we expect that. So again, in your question, so if you send me this question, you're texting it to me, my question to you will be, are they healthy, non-diabetic, or are they a diabetic? Because if they're not a diabetic, I want the hemoglobin A1C to be less than 6. If they are a diabetic, 7, less than 7. Okay, I think you're good with that. Somebody says big family, yeah. I'm the youngest of all of them too. Okay, so you're good with that. You're good with the polys. Let me go over the pathophysiological process. Let me make sure I have that little one. Yes, I do. Okay, I'm going to cover the pathophysiological process to diabetic ketoacidosis, and then you'll see why the polys, okay? Because you do need to know why they're peeing, eating, and drinking a lot, okay? So we talked about the diagnostic test. We're going to talk about the polys some more. We'll do wounds. Okay, just want to make sure I covered everything. So let's manage. So we manage, of course, diabetes with the diet. You need to consume less, okay? Simple carbs. We talked about those when we did nutrition. So this is not a client who can just go and eat cake and syrup and all of that like my sisters do. Okay, you're not supposed to do that. Those things are supposed to be limited and taken out of your diet. Okay. And they should be exercising, and they should be taking their blood sugar before they exercise. They need a snack before they exercise in case they lower their blood sugar more. We're going to talk about hypoglycemia, but this requires a lifestyle change, okay? So before exercises, clients who require insulin, they should have a carb before that. Don't just go and exercise and imagine you're taking your insulin, which is going to lower your blood sugar. You go and exercise and you didn't eat. Yikes. Prepare for your blood sugar to go down. And hypoglycemia is more dangerous than hyperglycemia, okay? So if you have these two clients who's a priority, your hypoglycemia, you go hypo quicker than you go hyper, okay? So keep that in mind. So now let's talk about insulin. So we're talking type 1, of course, if we're talking insulin, okay? So we use type 1 diabetes mellitus, we use insulin for type 1 diabetes. In type 2, we have options of using the insulin with a combination of the oral hypoglycemic agents we're going to talk about. So a couple of things you need to remember about insulin. Regular insulin is the only, you remember those words, we're careful about them, but it's true here. Regular insulin is the only insulin we give IV. Don't miss that silly question, okay? You're not going to give any other type of insulin IV. The others are given sub-Q, right? Okay, so keep that in mind. NCLEX question. You're also going to teach the client to rotate. You don't want to keep injecting in the same site. You end up causing necrosis. So silly little things like that. We're going to talk about mixing clear and cloudy. So these little things you have to teach the client about. So this is just nursing interventions. So now don't forget to monitor for hypoglycemia, okay? Because remember, they're at risk of that as well, even though they're diabetic, okay? So these are little mnemonics for you. I always remember this one, cold and clammy, need some candy. If that works for you, adopt it. There's some other ones here. So I like putting the mnemonics because they help you remember the information. So once your blood sugar is 50 or below, you're hypoglycemic, and you need to, if they're awake, give them sugar, okay? Give them something with sugar, glass of milk, orange juice, something. But if they're unconscious, everything you do is gonna be either IM, sub-Q, IV is not gonna be by mouth. So pay attention whether they're conscious or unconscious, okay? And know the signs and symptoms of hypo and hyperglycemia, okay? So here's the little mnemonics here for you can play with later. Let's DKA this client. Okay, so diabetic ketoacidosis. So this is a complication where your blood sugar is well over 350. The name tells you a lot. Ketoacidosis. So keto, there's elevated ketones. Acidosis, they're acidotic, okay? So that elevated ketone caused that sweet odor to the breath. That's an NCLEX question. NCLEX wants to know that you know why is that sweet breath smell to their breath, the ketones, okay? So the ketones, the elevated ketones cause that sweet smell to their breath. The metabolic acidosis cause the Kussmaul's respiration, okay, where they go, okay, that's the Kussmaul's respiration. So let's talk about the pathophysiological process to DKA, and then I'm going to come back to the management, okay? So this is what's happening with your diabetics. So they eat, and what they eat gets broken down into sugar, but there's no insulin to take it into their cells. So the body tries to compensate. The body makes more sugar, but it doesn't matter how much sugar the body makes because there's no insulin. So that's why when you take the blood sugar, it's sky high because the body's trying to help. But it doesn't matter how much sugar the body makes, there's no insulin. Okay, so then the body's trying to compensate some more. The body needs energy. So instead of trying to break down the sugar or make more sugar, it breaks down fat for energy. Now that is a dangerous thing to do because when you break down fat for energy, you leave behind a debris called ketones. Okay, so that toxic acid, ketones, that's what it is. It's a toxic acid, which is a byproduct of fat breakdown. So when your body breaks down fat for energy, it causes that elevated ketones. Okay, so now your body's trying to get rid of all that excess ketone. That's why they go to the bathroom a lot. That's why they become thirsty a lot. That's why they're always hungry. Okay, so that's the pathophysiological process with the polys too. When you think about the breakdown of the fat, it is never good to break fat for energy. Okay. So now how do we treat this? We're going to treat it with regular insulin IV and hydrate them. So IV fluid and regular insulin. And do me a favor, pull that potassium. Okay, you want to make sure, because remember, they were acidotic, so they were hyperkalemic. So you always want to pull the potassium to see what it is. Okay, so treating with IV insulin and fluids. Okay. All right, there's another condition on your NCLEX called hyperosmolar hyperglycemic. This used to be called hyperglycemic hyperosmolar non-ketotic coma. They changed the name, thank God. Such a long name. So now it's just hyperosmolar hyperglycemic. So now this is a non-diabetic whose blood sugar is over 600. This is what caused this one. You have a client who's on tube feeding, you're giving it too fast, and you're giving it without supplemental water, which is a big no-no. You could sue somebody for that. That's just, unethical. So we all need water on a regular. You can't just keep giving somebody tube feeding with no water. You're dehydrating them. And if you give that tube feeding too quickly, this is very dangerous. You see here, it causes nephropathy, neuropathy, okay, macrovascular problems, coronary artery disease. You could kill the client doing nonsense like that. So these clients' blood sugar are well over 600, pH is 7.4. They don't have any ketones because remember, they're not a diabetic. This is due to food, G-tube feeding being given too quickly, okay, which can be controlled, okay. All right, this little table here you have to spend time with. There are a few insulin tables out there. Please go by this one because this is the one from the NCSPN. So I know it's the latest one, okay, it's the most accurate one. So please use this one. There are a few old ones out there because some insulins have been taken off the market and all of that. So make sure you're using an up-to-date table, okay? So you need to know the onset, the peak time, and the trough time, the duration of each drug, not just insulin, but since we're talking about insulin here. Every drug has an onset time. How long does it take to start working? Every drug has a peak time. When is the drug at its maximum? And every drug wears off where you need your next dose. So never ever give insulin without food in front of the patient, literally, never do that. You need food in front of the patient if you're gonna give insulin, because look at this. Insulin has rapid acting, short acting, intermediate, long, and very long acting. Your rapid actings are regular insulin IV and Lispro, Humalog R. When you give those insulin, they start working in 10 minutes. Imagine you give this drug and you can't find food. They're gonna be hypoglycemic on you in a moment. And with 30 minutes, the drug is gonna be at its peak. They need a snack. So this is how they phrase these questions. Mrs. Jones was given Humalog R at 8 a.m. When do you expect to give her a snack? 8:30, because that's when the drug peaks. Okay, about half an hour, okay, to an hour and a half, the drug peaks. If it's Humalog R, it is out of Mrs. Jones' system within 3 to 5 hours. So you can see why physician makes a rapid acting with an intermediate acting. So the clear and cloudy question, right? So a physician could order for Mrs. Jones to get 3 units of Humalog R mixed with, okay, 5 units of NPH, okay, because within 3 hours, the Humalog R will be out of Mrs. Jones' system, and within an hour of giving this, that's when the NPH is going to start working. It doesn't peak until hour number 4. So then when the Humalog R is out of her system, the NPH is starting to work, and then it's there for 10 to 18 hours. So this is why physicians, mix these insulin, depends on what the client needs, but you need to spend time with this table. I know Glargine is on your NCLEX for sure. I remember a student calling me. I remember exactly where I was when I took this call, and she was like, what is Glargine? And I'm like, Lentis. But she knew Lentis. So this goes to show you need to know your generic names, not the brand ones, okay? So please work on your generic names. These are little mnemonics for you to help you remember, the peak and duration of them. If they help, beautiful, okay? All right, now let's talk about mixing clear and cloudy, okay? Let me grab some pencils so I can demonstrate. Okay, so physician says give 5 units of clear insulin and 5 units of cloudy, okay? 5 units of regular, clear, 10 units, let's double it, 10 units of NPH. The goal is to not mix cloudy into clear, okay? So you always wanna pull out of your clear first, then pull out of your cloudy. So let's say physician orders 5 units of regular, okay? 10 units of cloudy. You will put in your syringe, okay, your needle, you will put a total of 10 units of air, because remember, you need to put air in your vial so you could pull the insulin out. So you're going to put air in your cloudy first. So you have 15 units of air in your syringe, you're going to put air in your cloudy first. So put 10 units of air in your cloudy vial, and then you're gonna go to your clear and put the 5 units. And then you're going to stay in your clear and you're going to pull out the 5 units that's ordered. And then you're going to pull out of your cloudy. So you put air in your cloudy first, then you put air in your clear, you stay in your clear, you pull out your units out of your clear, then you go pull out your units out of your cloudy. You don't ever want to mix those, because then you mix putting cloudy into clear, and that's a no-no. There's a video on that on Riggs and Clicks. Please take a look at it. You could very well get this question. Okay, one more little crazy topic I want to cover. It's on your NCLEX. You probably forget about these two because we just forget about them in nursing school. Dawn's phenomena and Samoji effect. You're probably like, huh, what are those? Did we learn them? Yeah, you did. Hopefully you did, but you forgot about them. So let me go over them. Dawn's phenomena and Samoji effect. So those are from diabetic clients, but it's a hormonal problem happening, okay? So the imbalance in the hormones are causing these clients to be hyperglycemic about 8 in the morning, 7, 8 in the morning. So how you diagnose them is very unique. Both of them, you need to do a 3 a.m. blood sugar, literally 3 a.m. The physician will order a 3 a.m. blood sugar. If this is Samoji, they will be hypo. You see the O in Samoji? Hypoglycemia at 3 a.m. If they have Dawn phenomena, they will be normal. The A in Dawn, normal. So that's how I remember them. Both of them, okay, you do a 3 a.m. blood sugar. Samoji is hypo, Dawn's is normal. okay? But both conditions have a rebound hyperglycemia, where at 8 a.m., they're hyperglycemic, both conditions, okay? How do you treat them is the other NCLEX question. So how you diagnose them is the 3 a.m. blood sugar. How you treat them, if it's emoji, where they're hypoglycemic at 3 a.m., the physician will order a reduce their bedtime PM insulin. If it's dawn phenomena where they're normal at 3 a.m., the physician will increase their PM insulin, and that's how you treat those, okay? Don't mix them, okay? I have little charts for you about them. You can take a look at these little mnemonics. All right, so a couple of things I want to mention with the diabetics, and then I'm going to go over the oral diabetic agents, and then we're done. All right, so foot care. Remember I mentioned that. You don't ever want to see wounds in diabetics because they don't heal like you and I. That's why they need that increase in, in protein and all of that. I know, let me see, probably about 5 people who have had an amputation who are diabetics, and it's from a little scratch. Okay, my mother's one of them. She didn't have to have a full amputation, but she had to have most of her foot scraped out. My father-in-law, BKA. Yep, a couple other people crossing my mind. Diabetes is a nasty, nasty disorder. So when you see wounds in these guys, worry because they don't heal. So you need to teach them foot care. They need to take a mirror and look under their feet. They need to not cross their legs. No more tight stockings, leggings, socks. Okay, no more walking barefoot. They cannot clip their own toenails. They need to go see a specialist, a podiatrist. So they have a lot of maintenance, those guys. Okay, no wounds in the diabetic. Increase their protein. Okay, so now let's talk about these oral diabetic agents. A lot of them you're very familiar with. Okay, metformin you're familiar with, glucophage you're familiar with. Okay, so Avendia that has a commercial, so does Actos. Yeah, a few of them have commercials. So let me go over a couple of things with them. So now your oral anti-diabetic agents, they have contraindications. We never use those in children. We never use those in type 1 diabetes. We never use those with severe renal and liver problems, and we don't use them in pregnancy. Okay, so a lot of contraindications, and you already know, you having the food in front of the client before you give these drugs. Okay, administer them right before the meal. Other than the contraindications and knowing when to give them and monitoring the blood sugar and making sure you give a snack, at certain times so they don't go hypoglycemia, there's not too much with them. I want to point out something with Exubera though. Exubera is an inhaled insulin. It's becoming more and more popular. Exubera could cause bronchospasm. So if they have a history of asthma, COPD, or any type of respiratory problem, you're not going to use this one. Okay. But other than that, that's it. These are some major complications of diabetes you already aware about. The extremities I've already pointed out. The neuropathy you know about, okay, that decrease in sensation, because they don't have, the blood is not flowing throughout their body like you and I. So they're at risk of eye problem, kidney problem, cardiac problem, extremities problem. Crazy, right? So those are micro versus macrovascular problems. Great little chart. So everything we put in our mouth, we go through mastication, right? We chew the heck out of it. And it goes down our esophagus. I'm doing a quick anatomy here. Down our esophagus. And at the lower part of the esophagus is the esophageal sphincter, okay? Lower esophageal sphincter, which is a very tight space. Your food goes down, it's supposed to stay there, okay? That's why sometimes if a patient has a hernia, okay, I have a nice picture for you of a hiatal hernia, the food may go back up. Or if that section loosens, they may have GERD, heartburn. Okay, so but once your food goes down, passes the sphincter, it's not supposed to go back up. It goes into your stomach, and then it goes past a another tight area, or supposedly tight. But some conditions, we're going to talk about the newborn having an abscess there where it prevents the food from moving forward. But generally, if there's no problem, the food leaves your stomach and go past the pyloric sphincter right here. Okay, after the stomach is the pyloric sphincter. It's supposed to go flow smoothly into the small intestine, but we're going to talk about an abscess there for the little ones called pyloric stenosis. But after it does that, it starts into the small intestine. Now there is a vital area there, just in case you get this question. So the beginning of the small intestine is the duodenum. The duodenum is connected to some other organs, okay? So you have the pancreas we just talked about. You have the gallbladder over here, and then if you have the full picture, which I have coming up, is the liver. The gallbladder has a duct, the liver has a duct, the pancreas has a duct. Those three ducts meet, and they all meet at the beginning of the duodenum, and they release a lot of enzymes. Why is this important? Because we're going to talk about a condition where you need to know what I just taught you, okay, with the pyloric sphincter. So the enzymes are bile. These children that have the pyloric sphincter, they vomit and it does not have bile. Why? Because it never got to the duodenum. Okay, we'll talk about that again so it sticks to your long-term memory and you get it. So after the duodenum, you have the jejunum, you have the ileum. That's all the small intestine where fluid goes into. That's why that stool is liquid. Okay, fluid goes into it with the small intestine. Once it hits the large intestine, fluid starts to come out. That's why the stool gets harder and harder and harder. You need to know that because if I tell you the patient has an ileostomy, it's very different than a colostomy. Okay, with a colostomy, the stool is more formed, especially if it's a descending, okay, colostomy. So that's the GI tract, and you see the appendix there. We're going to talk about appendicitis, okay? So here's another picture. You could see the duct underneath the liver. You could see the gallbladder duct and the pancreatic duct. They all meet at the duodenum, okay, at the beginning of the small intestine. So some of the conditions we're going to talk about, you may need to do an abdominal girth on a regular, okay? This is a picture of an umbilical hernia. I have a picture of a hiatal hernia coming up, just so you know, this is a quick anatomy. Now, the other thing I need you to do for this section, you need to know what organs are under each quadrant of your abdomen. What organs are under the right upper? What organs are under the left upper, right lower, left lower? Those are basic questions. If I tell you the patient comes in with right lower quadrant pain, what organ could possibly be, you know, infected or inflamed or swollen? You see what I'm saying? So know what organs are under each quadrant, please. Okay, so here's another one for you to work on, okay? All right, so now let's talk about a couple of conditions. Actually, before we do that, I want to go over the job or function of the liver, okay, because we're going to talk about hepatitis. So part of GI is the liver, okay? So the liver is very important, okay? Let's go over a few of the important things that the liver does, okay? Its job. So the liver also metabolize, okay, fat, carbohydrate, protein. Okay, it produces all this necessary bile to break down fat that we eat. It converts glucose to glycogen for storage for future energy. It converts glycogen to glucose and it gets released into the blood. It forms glucose from fat, like you saw earlier with the diabetic ketoacidosis. It stores fat. It converts amino acid to ammonia. That is an important job that you need to know about because we're going to talk about encephalopathy where the ammonia level rises because the kidney can no longer control or eliminate, excrete that ammonia. So the liver converts amino acid to ammonia. Very important, keep that in mind. Okay, ammonia to urea because we have to excrete it. Also, the liver synthesizes a lot of factors that helps with blood clotting. So you need to keep in mind all this job that the liver does. So we need our liver to function properly, okay, in order for us to be okay. We're also going to talk about the pancreas, but not in the sense of diabetes now. We're going to just mention it for pancreatitis. Nothing major with that one. The gallbladder also we're going to talk about with gallstones. Okay, so these are lab work, okay? Pay attention if there's any special prep, but most of them there are no special prep. Okay, but you also need to know if I'm pulling this lab, what organ is impacted. For example, if the physician orders an ammonia level, it's the liver. If the patient orders your AST, your ALT, those are liver. If the patient orders the bilirubin, liver. You see what I'm saying? So know what organ we could possibly be dealing with depending on what we're ordering, okay? So these are not so common. Let's talk about GERD real quick. Nothing too heavy with GERD. So I talked to you about the lower esophageal sphincter. If you see the picture on the top right hand, you see how tight the lower esophagus is. That's how it's supposed to be, but sometimes it loosens. So the food that the client eats goes back up. The little ones, your newborns, that's a very easy condition to fix or maintain, and it goes away with the little ones. You can thicken their food, okay? If it's an older person that drinks coffee and that's the cause, get rid of the caffeine, get rid of the acidic food. If you smoke, stop smoking. So depending on the cause, okay, will be the treatment. But as far as pharmacologically, your H2 antagonist and your PPIs, proton pump inhibitors, are the two class of drugs for this condition, okay? Here's a nice picture. It could be caused by a hiatal hernia. Now let's talk about pyloric stenosis. So this one is on your NCLEX. You see how after the stomach is this sphincter. Sometimes children develop a mass there, okay, and it causes their food to not be able to continue through their GI tract. So they have what we call pyloric stenosis, okay? These children have progressive projectile non-bilious vomiting. Why non-bilious? Because it never got to the duodenum where they would be introduced to the bile. So pay attention to that. So if I tell you the child has non-bilious vomiting, that's most likely the cause, because the other conditions we're going to talk about, the vomit would have bile, okay? The only treatment for this is surgery, okay? You can look at constipation and diarrhea. Okay, celiac disease, we covered gluten already when we did nutrition, so I just want to recap here. Remember, with celiac disease, this is an inability to break down gluten, okay? And gluten is found in certain food, like the little pneumatic, we have brow, barley, rye, oats, and wheat. So you can help the client fix this by helping them change their diet. So stay away from anything that's high in gluten, what we've just mentioned. They end up with nasty stomach ache and fat. They poop fat, steatorrhea, okay? Very painful condition, but they can control it with what they eat, okay? So this is a recap. Intussusception, I believe is still in your NCLEX. Students still having this. I don't know why they're still giving these questions. They're not that common. So, but don't mix intussusception. I'm going to come right back with Hirschsprung disease. Okay, they're very different. So intussusception, if you see here in the picture on the left, so you have the large intestine and then the small intestine loops into it. That's intussusception. A lot of times this happens at birth. Okay, you can tell because the child doesn't pass the meconium, and then you're looking into it and then you see this. It's very common in this area, but it could happen anywhere. Another NCLEX question with this is where the child poops what we call current jelly stool. If you see in the picture here on the top right, their stool looks like jelly. It doesn't look like meconium, okay? How do we fix this problem? So the physician will order a barium enema for this child. And we already talked about barium enema. Whenever you're doing a diagnostic test with a barium enema, priority is to make sure that the client passes the barium because it hardens in their GI tract. So the moment you know we're doing this, you know what to do. But a barium enema is administered and the physician will do like an air pressure, like literally push air into the GI tract to get that part of the GI tract out of the other. You know it's resolved when the child is having a normal bowel, okay? That's it with that one. Hirschsprung is very different. In our GI tract, we have these cells. They're called ganglionic cells. This child is born with a portion of their GI tract where they do not have ganglionic cells. What ganglionic cells do is they cause motility. So they cause, when you eat your food, they cause it to go the direction of your anus. So now you get to this part of the GI tract, they don't have those cells. So the stool will accumulate, it balloons up. And this condition is called megacolon. So the child gets the food in, formula, whatever it is, but when it gets to that portion of the GI tract, it cannot continue, no more motility. So it stays there and it balloons, very dangerous. This could perforate. The only treatment for this is to cut the bad part. Okay, they could have a temporary colostomy bag and then re-put it back together, re-anastomose it, okay? Another question with Hirschsprung deals with the type of stool. If the child even passes any stool, it's gonna look like a little bow, a little ribbon, like a child's barrette, okay? So we call that ribbon-like stool. And ribbon-like stool is with Hirschsprung disease. Jelly-like stool is with intussusception, okay? Like you see here. So intussusception is with the jelly-like stool. The ribbon-like stool is with Hirschsprung disease. And it makes sense because look at the colon. As it balloons, it kind of looks like a bowl, bunch of little bowls. So that's with Hirschsprung, okay? That type of stool. All right, appendicitis. So appendicitis, you know there's an infection with the appendix, and you know the appendix is in the right lower quadrant. By the way, if you get this question and it's a female client, do a pregnancy test. Rule out ectopic pregnancy, because ectopic pregnancy presents similarly to appendicitis, okay? So you know it's rare in young children, okay? Very painful, okay? They might get a fever, nausea, vomiting, all of that. Couple NCLEX things with this one. So our priority, your priority, is to make sure this doesn't burst, okay? So we wanna make sure we don't do anything that's gonna burst. There's no rectal temperatures, no cathartics, no heat in the area. You're protecting this from bursting, because if it bursts, you now have a medical emergency, because imagine bacteria in the abdominal cavity. You're at risk of peritonitis, very dangerous. So make sure this doesn't burst. There is also a hotspot question with this, okay? So there's an area with appendicitis where the pain is most severe, and that area is called McBurney's point. So you see here in the picture where the belly button is and the upper pelvic bone, in the middle of that is called McBurney's point. This is a hot spot. So if you get this where they tell you where would the pain be most aggravated or McBurney's point, there's an invisible box where you see the little red dot, okay? So that area is where the pain is most intense. That's McBurney's point, and that's a hot spot question. Okay, so don't forget, if it's a female client doing HCG serum, make sure they're not pregnant. It's not an ectopic pregnancy. Okay, no enemas, no cathartics, no heating pads. Again, all of that is gonna burst this thing. Your job is to make sure it doesn't burst. All right, our next topic is pernicious anemia. Pernicious anemia is not like regular low red blood cell count anemia, very different. Pernicious anemia is anemia caused by a failure of intrinsic factors absorbing vitamin B12. So vitamin B12 is absorbed in your stomach. You have a factor in your stomach, an intrinsic factor that absorbs and picks up B12. Patients who have had gastric bypass, part of their stomach removed, no longer have those intrinsic factors. So they can no longer absorb B12. So they will need an injection of B12 for life. There's a diagnostic test we use for this called Schilling's test. Schilling's test is a multi-step test to measure absorption of B12, okay? It involves oral B12 and an injection of IM-B12, and then we collect urine samples. So Schilling's test, you need to know for NCLEX, is a multi-step test to measure absorption of B12. So now if they've had a gastric bypass, they no longer have those intrinsic factors, they'll need the B12 injection forever, okay? For life. So now don't forget, pernicious anemia affects the GI and it affects neurological. The GI symptoms usually resolve once you get their B12 within range, but the neurological do not, okay? So symptoms, GI symptoms of pernicious anemia are reversible. Neurological symptoms of pernicious anemia are not reversible. So the sooner you treat this, the better. The anorexia, the nausea, vomiting, diarrhea, abdominal pain, the swollen tongue, okay, the beefy red tongue, all of that goes away, okay, once you treat this. But the imbalance, coordination, that doesn't go away once you let it happen. So the sooner you treat this, the better, okay? Don't forget about the Schilling's test. It is on your NCLEX, okay? It's a two-step or multi-step to diagnose this, okay? Ulcers. So ulcers, you have gastric ulcers, so it could be in the stomach. You have duodenal ulcers, could be in the duodenum, the beginning of the small intestine. But an ulcer is an ulcer is an ulcer is an ulcer. It doesn't matter where it's at. There's an NCLEX question here that deals with the pain and the weight gain or loss. So let's talk about that. With the gastric ulcer, the ones that are in the stomach, these clients tend to lose weight. Why? Because every time they eat, it hurts. So they don't eat. The opposite for duodenal. Duodenal ulcers, they tend to gain weight. Why? Because every time they eat, they feel better. It takes away the pain. That's your NCLEX question with those two. The pain is with gastric ulcers. Okay, so now both of them, you know, there's a risk of perforation, like you see here in the top right hand. You literally have blood dripping in your abdominal cavity, which is very dangerous. Okay, so they end up with what we call the board-like abdomen. You tap on their stomach, it sounds very rigid. Okay, both of them we're going to do in stool for occult blood. Okay, the risk factors for both of them are aspirins, NSAID, H. pylori, nasty little bug. Okay, Helicobacter pylori, nasty bug. So those are, they have the same risk factors. We do the same diagnostic test. It's just the pain is different depending on which one you're dealing with. But an ulcer is an ulcer is an ulcer is an ulcer. We want to prevent perforation, okay? So some of the treatments involved are anti-infective. Okay, Flagyl is a good one. Don't forget, these are anticholinergic, so they're going to dry the hell out of these clients. You already know that. I've talked about anticholinergics to death. Your H2, okay, antagonist, Tagamet, Zentac, Pepcid, your proton pump inhibitors, okay, Leprozole, Prilosec, Prevacid. You're very familiar with this. There's so many commercials about them. Some of them over-the-counter stuff like Mylanta, Maalox, Tums, those are, you're very familiar with them. But these clients may have to have a Billroth 1 or a Billroth 2. Remember those guys? So Billroth 1, this client may have to have part of their stomach removed and part of the duodenum removed. A Billroth 2 is more severe. Not only do they have part of their stomach removed, but all of the duodenum gets removed and even part of the jejunum. So more of the GI tract is gone. So any client who have had a Billroth 1 or Billroth 2 will have what we call dumping syndrome. You knew I was going to go there. Dumping syndrome is on your NCLEX. The name tells you a lot. Your food rapidly goes through your GI tract. Okay, so dumping syndrome is rapid emptying of the stomach. When the food goes from your mouth to your butt so quickly because you have less of a GI tract, you're going to get the tachycardia, you're going to palpitate, you're going to have syncope, you're going to be sweating, diaphoresis, diarrhea, abdominal pain, nasty, nasty feeling. So your job is to teach the client certain measures on how to keep their food in their GI tract the longest. That's our goal. The food is going through the GI tract too quickly. So we want to keep it in their GI tract longer. So this is the client who eats and lays down. Okay, this is the client who never eats with water or fluid, not just water, fluid. No more fluid with your meal because it causes the food to go through your GI tract too quickly. Okay, so no more milk product, nothing that's going to cause diarrhea because we have a diarrhea problem with this condition. And of course, anybody who's had Billroth 1 or Billroth 2 will be at risk for pernicious anemia, and they'll need the B12 that we talked about earlier. So this is like a whole cycle, okay? So this little mnemonic is a really great one that talks about some of your NCLEX question. The dumping syndrome happens about 15 minutes after they eat. Okay, so this is a client who cannot just go and have a Snickers bar. There's too much simple, you know, sugar. So they need to change their lifestyle. It is what it is, okay? Nice picture. Imagine this is how much stomach you have left, okay? Yeah, anyway, you get it. All right, ulcerative colitis versus Crohn's disease. Don't mix those two. So ulcerative colitis, they have an inflammation throughout the large intestine. Whereas Crohn's disease, I'm going to come right back, the inflammation is in patches, it's in segments, okay? That's the difference between those two. And don't think of this like an old people disease. This could start very young, 15 years old for both of them, okay? But it is an inflammatory problem. So with ulcerative colitis, the entire large intestine is inflamed, okay? Whereas with Crohn's, segments are inflamed. Now, both conditions have remission exacerbation, remission exacerbation, remission exacerbation, okay? And they also cause impairment of fat-soluble vitamins, which you know are the ADEK, okay? ADEK. So treatment, okay, ulcerative colitis is easier to treat than Crohn's, okay, because of the the patches, but both of them, they need to have an ileostomy or a pouch like you see here in this picture. They may have an ileal reservoir, but they may have to have part of their GI tract removed, okay? So some of the pharmacological intervention we can do are the steroids to decrease all of that inflammation, because remember, that's the problem. So steroids like deltazone, okay, prednisone, or salucortef are great. It helps to decrease that edema in the GI tract. We could use immunosuppressants if it's an immune disorder causing it. Okay, we could use some of those anti-infectives that we talked about earlier. We could use Bentyl, and then they have a lot of diarrhea. So your anti-diarrheals like Imodium and Lomotil come into play. So different treatment, but if this persists, they may have to have, part of their bowels removed, which we try and avoid, if we can. So same analogy with Crohn's, okay, treatments pharmacologically are the same. All right, diverticular disease. So with this condition, pay attention, because diverticulitis is not the same as diverticulosis. So one more time, diverticulitis is not the same as diverticulosis. So let's go over the difference. Diverticulitis is the inflammation. The tract is inflamed. Okay, like I had a really nice picture of that. Oh, it's on the other side. Okay, so when you have diverticulosis, you have the outpouching. So you see here in this picture, you have these little pouch, okay, where food could get stuck there. So when you have that condition, okay, which is diverticulosis, the treatment is high fiber, high residue. Flush this tract, flush this GI tract, okay? Whereas when it's the inflammation, diverticulitis, rest the bowel, okay? NPO, 2 days, okay, to fix. So pay attention which one you're dealing with, because the treatment is different, okay? All right, so let's talk about bowel obstruction real quick. So if a patient has an abscess growing in the GI tract where the bowels can't continue to their anus, you're going to have a little something we call reverse motility. So motility is bowel moving towards your anus. So now when you have reverse motility, it's bowel moving towards your mouth. So these clients do vomit stool, okay? There's a nice high-level question here that I want to go over. So a client with a bowel obstruction that has reverse motility is at risk of metabolic acidosis, okay? So even though you're vomiting, what you're vomiting is stool, and stool is base, okay? So that's why they're acidotic and not alkalotic. We do teach you, with vomiting, you're at risk of alkalosis because you're getting rid of the acid in your stomach. But in this condition, what they're vomiting is stool. So they're at risk of acidosis. I'm hoping that makes sense. I'm going to say it one more time, just in case. So with a bowel obstruction, you're vomiting stool. So it's as if you're pooping, okay, you're getting rid of base, so you would be left with acid. So just because you're vomiting it, okay, doesn't mean you're going to be at risk of alkalosis, but because you're vomiting base, you're at risk of acidosis. What's left is acidosis. So even though it's coming out of your mouth, okay, you're pooping, you're vomiting stool. Okay, I hope that makes sense. So bowel obstruction, you're at risk of metabolic acidosis. Okay, so NCLEX question there. So we may need to, decompress your GI tract. With these conditions, by the way, whenever you're managing pain for GI issues, you always want to avoid morphine or codeine because those cause constipation. So with a client with bowel obstruction, I don't ever want to give medication that's going to cause constipation because we kind of already have that problem. So one more time, any condition where you already have constipation, stay away from morphine and codeine because they cause constipation. Okay, so line of drugs. Okay, that's a nice and crisp question too. Okay, now the tubes. So pay attention to where the ostomy is. Okay, so ostomy is a surgical opening, right? But where is that surgical opening? You do need to know and process that, because that tells you what type of stool you should expect. So if it's an ileostomy, it's coming from the ileum, okay, which is still the small intestine. So you're expecting liquid or pasty stool. This is not going to be formed stool, okay? So with an ileostomy, which is in the small bowel, you never need to use laxatives, okay, because the stool is already watery. Remember when I did the anatomy, I talked to you about fluid going into when it's a small intestine, and when it's the large intestine, ascending, transverse, descending, fluid is coming out. That's why when you have this urge to defecate, go defecate. The longer you hold onto that stool, the harder it becomes, and you risk constipation, okay? So now here are some pictures. So the first one would be in the sigmoid, and then the second one going across would be the descending, okay? And then this is a double barrel example in the transverse colon, the third one on the top. And then on the bottom, the first one on the bottom is an ascending colostomy, okay? The middle one is an ileostomy, okay, and the last picture on the bottom right is a picture of a cock pouch. So you would need to teach the patient how to empty that. So here's a list of all of them. When you go over this again, pay attention to what type of stool come out of which one. The closer the food gets to the anus, the stool gets to the anus, the more formed it is, okay? So these are some nice pictures, your colostomy bag. I want to talk to you about the skin. So right after an ostomy, if it's within the first day or 2-3 days, you expect, you know, maybe for it to be swollen a little bit, red, okay, because you're right after surgery. But as the days and time go by, remember, it's your skin that's taken and protruded out. So it's supposed to be red, you know, because our conjunctiva, our cavity, our inner cavity is pink. So normal pink or ruddy color is expected, because remember, that's your skin pushed out, okay? So pay attention right after. It's common to have some slight bleeding right after surgery, a little bit of edema right after surgery. But if we're talking days, weeks later, that's not supposed to be, okay? But skin is obviously a concern, okay? Now let's talk about hepatitis. So hepatitis is a disease of the liver, okay? Whether it be viral, bacterial, toxins, overdosing, poisoning, it affects the liver, okay? So hepatitis definition is acute inflammation disease of the liver, okay? Now, the liver has potential to regenerate, but sometimes there's damage that causes permanent damage or irreversible. Once you scar, okay, that is irreversible damage. We're going to talk about that. Let's cover the hepatitis, okay? There's hepatitis A, B, C, D, E, and others, okay? What you need to know, we already talked about how you catch it with the safety and infection control portion of the review, but let's recap here, and I'm going to focus on the signs and symptoms. So it doesn't matter which hepatitis A, B, C, D, E, or others, they all affect the liver. So all of them, you're going to have a right upper quadrant pain. You're going to have GI effect, nausea, vomiting, anorexia, weight loss. Okay, the GI problems, all of them, the fever, the chills, the jaundice, because they all affect the liver. So it doesn't matter which one. I'm covering the signs and symptoms for all of them now, because they all have the same sign and symptom. Doesn't matter which one. The dark urine, okay, so all of them cause this. So you need to know how you catch it, and you need to know whether there's a vaccine or not, okay? A and E, they're vowels, right? A, E, I, O, U are vowels. A and E are vowels. If it's a vowel, it usually comes from the bowel, okay? So that means oral fecal. That means you go to the bathroom, you wipe your butt, you don't wash your hands, you fix a sandwich, you eat it, or you drink dirty water, you eat dirty food or uncooked food, you risk getting hepatitis A or E. They're vowels. They're transmitted via fecal oral, okay? There is a vaccine for A, okay? There is no vaccine for E. Hepatitis B, B for blood, body fluid, blood, semen, saliva. There is a vaccine for B. We healthcare providers are at risk of hepatitis B because we're at the forefront. We're injecting patients all the time. We're at risk, you know, of being exposed to their body fluid, semen, blood. Okay, so that puts us at risk. There is a vaccine for Hep B. Hep C is via blood and semen as well, no vaccine. Hepatitis D, there is no vaccine, and that's also via blood, okay? So we treat all of them with rest, okay, nutrition. We have to change the diet. Don't forget the liver is not 100%, so you don't want to give stuff like increased protein, because protein takes a long time to break down. We already talked about that. So if anything, you want to decrease everything that's going to cause the liver to work harder. Okay, but nutrition, rest, especially if it's, you know, severe, you don't want to stress the liver, okay? So that's what you need to know for the hepatitis. So what I did was I went down and broke them down even further, because some of you, that's how your brain works. So I go through all of the hepatitis again. So now let's continue to fail the liver, and then I'll give you a break. So what happens with the liver, as the liver, remember all the jobs we went over, you know, that the liver is responsible for. So as the liver breaks down, there's a condition that happens called cirrhosis. When you have cirrhosis, that is irreversible damage. The liver has scarred. Once there's scar tissue, no more blood is flowing through that area. But a lot of different causes for cirrhosis. Those who abuse alcohol are at risk of Lennox cirrhosis. When the cirrhosis is caused by hepatitis that we just talked about, that's called post-necrotic cirrhosis. When it's from a biliary or one of the ducts we talked about, either from the gallbladder, the liver itself, or the pancreas, that ends up affecting the liver, that's called biliary cirrhosis. Sometimes the liver fails from heart failure, especially right-sided heart failure. That's called cardiac cirrhosis. So the cause changes the name. The most common one, obviously, is Lennox cirrhosis from alcohol abuse, okay? So that happens from scar tissue, okay? That will not regenerate. You know what the signs and symptoms are because it's the liver, okay? So now let's talk about diagnostic tests. So yeah, we're gonna pull in ALT and AST, look at all the enzymes. There's an extra test that you need to know about. This is on your NCLEX, I'm certain. There's a diagnostic test called endoscopic retrograde cholangiopancreatography, short ERCP, okay? So with conditions like liver, pancreas, gallbladder, we will do an ERCP. So an ERCP is a scope that goes down the esophagus, through the stomach, past the pyloric sphincter, and right at the duodenum where those three organs, ducts meet, which is called the common bile duct. So an ERCP will give you that visualization, because we want to rule out that this liver failure is not due to a blockage of the ducts. Okay, so one more time, with conditions like liver, gallbladder, pancreas, we do an ERCP, endoscopic tube, retrograde, that goes through the cholangiopancreatography. So that's the route and the area we're going to visualize, okay? So diet, we're going to restrict protein. I already mentioned that, okay? We may decrease your sodium intake. We have to look and see if you're developing ascites, which we're going to talk about, and hepatic encephalopathy we're going to talk about. And obviously, if you're a drinker, it's time to stop, okay? So some of the complications with the liver failure could be ascites and hepatic encephalopathy. So let's talk about those complications. So one of them is also portal hypertension. So this is a picture of a portal hypertension client. So what's happened here, you have blood flow that is altered. So if I'm going to show you a picture of underneath the liver. So when that blood flow is altered, that resistance to the liver is impacted. So it causes an increased resistant flow to the liver. That causes what we call that hot belly. Okay, so the client is at risk of enlarged spleen, of course, anemia. And then you see that bottom picture with the little bleeds, that is the inside of the client's esophagus. So that risk of esophageal bleeds, okay? So very dangerous, condition. Here's a nice picture of the liver. You see the portal vein, there's a lot of pressure underneath the liver there, okay, not normal. All right, so as the disease progresses, the client could end up having ascites, okay, which is an accumulation of fluid in the peritoneum cavity in the abdomen. Okay, so fluid leaks into the intravascular space because of the job of the liver. It no longer can do it. So they are at hypoalbuminemia, which causes instead of fluid moving out of there, it's moving in, okay? That osmotic pressure causes that. So we need to get rid of that excess fluid, okay? So now the biggest problem really is hepatic encephalopathy. So remember, it was the job of the liver to change ammonia. It cannot do it anymore. So now ammonia is one of those substances that crosses the blood-brain barrier. So once this crosses the blood-brain barrier, it affects the client level of consciousness. So hence why the level of consciousness, the confusion, the stupor. So let's pull out the NCLEX stuff out of this. So hepatic encephalopathy is due to an impaired ammonia metabolism. Your liver is not functioning anymore. It cannot metabolize ammonia. It cannot change it to a form that can be excreted by your kidney. So that accumulates in your bloodstream, and it crosses the blood-brain barrier, okay? So they're gonna have memory loss. The other NCLEX question deals with the handwriting. So every day, you're gonna have this client either sign their name, write a sentence, something. You will see the changes in their handwriting as the disease progresses, okay? And they also have what we call beta hepaticus, where their breath also has a musty, sweet odor, kind of like a diabetic ketoacidosis, but different reason. So how do we treat hepatic encephalopathy? You need two treatments, two medications that are part of the regimen. One of them is neomycin, okay, sulfate. Why? That one is gonna stop intestinal bacteria. So when you pause that intestinal bacteria, you decrease that elevation in the ammonia. Now, the other drug that must be part of the regimen, which is on your NCLEX for sure, is lactulose. So lactulose, what does lactulose do? It converts ammonia into ammonium. Ammonium can be easily excreted. So awesome, that has to be a part of your regimen, okay, for hepatic encephalopathy. Okay, acute pancreatitis is not a big deal. We also do an ERCP with that one, okay? Your questions for pancreas really deals with diabetes mellitus, which we've already covered. But don't forget, I wanna mention, like for pancreatitis, don't forget your drug of choice is Demerol, okay, versus morphine. Use Demerol because Demerol causes less muscle spasm. Morphine causes muscle spasm. So avoid morphine with pancreatitis. Demerol is your drug of choice, okay? Gallbladder. So now cholecystitis is not the same as cholelithiasis. Cholecystitis, itis is the inflammation of the gallbladder. Cholelithiasis is the gallstones, okay? So your risk factors are high cholesterol, women who are fair, fat, 40, fertile, female, flatulent. You see on the bottom left, the 6 Fs. And then postpartum too, it's more likely you'll get this. So gallstones are more prone in female, whereas kidney stones are more prone in male. We'll cover kidney stones after the break. We talked about the ERCP. You're good with that diagnostic test. Again, Demerol is your drug of choice, not morphine. You know you're gonna filter the urine and all of that. There's an extra treatment I wanna go over called lithotripsy. Lithotripsy is the machine that will send a wave and break down the stones. If this client needs a laparoscopic cholecystectomy, here's a picture of that. So you can get your gallbladder removed the old-fashioned way, where we cut you nice incision and pull out gallbladder. But physicians don't do it like that anymore. If they can do it via laparoscopic method with the small little incisions, they prefer to do that because less of a scar, right? So when this procedure, when your gallbladder, oh, by the way, not just the gallbladder, any procedure that is done laparoscopically, that means CO2 is instilled in your abdominal cavity. Priority, they must pass gas. Literally, you need to ask them, are you having flatulence? Are you passing gas? Are you farting? If we're gonna talk layman's term, they need to, because if not, that air that is still in them is going to radiate and cause a lot of pain. Okay, so anytime a patient has a laparoscopic procedure, they need to be passing gas, okay? Don't miss that silly NCLEX question. So our kidneys maintain homeostasis. I keep talking about that from the beginning of the review. Homeostasis, we need the right amount of everything. So our electrolytes have to be balanced, and that is the job of the kidneys, in addition to so many other responsibilities. So the kidneys, this is a very nice picture of the nephrons in the kidneys. So we have more than 1 million nephrons, and their job is to filter. They're going to filter. Their job is secreting and reabsorbing. You have too much of it, they get rid of it in the urine. You don't have enough of it, they hold on to it until you at the right amount. So pretty big job. You cannot live without that homeostasis. If you have that imbalance, you'll end up dying. We need our blood to be cleaned and filtered on a regular, or else we'll have increased toxins in our blood, which will eventually kill us, okay? So whenever your kidneys is not able to filter, you see that nice picture of the glomerulus? So you've heard of the glomerular filtration. So we need the glomerular filtration rate to be 60 or higher. So whenever your GFR, glomerular filtration rate, falls below 60, you have a problem. That's when you'll need dialysis, okay? So filtration, secretion, reabsorption is vital job of the kidneys. So this is a back kind of drawing of the kidney. So you can see the little anatomy, okay, of the left one being a little bit higher. So if you want to assess and you want to palpate, you know exactly where to do so, okay? So quick little anatomy of that. So a few more things with the kidneys. So, you know, I have a friend who's born with 1 kidney. She's perfectly fine, but generally most of us have 2 kidneys. So again, the job is to remove waste from the body. So all of our blood gets filtered through the kidney and waste is removed, and electrolytes are balanced. So all of that takes place by the kidney, and plus blood pressure. Okay, our blood pressure is maintained in a couple of different ways with the kidney. So waste excretion is vital, reabsorption of nutrients is vital, maintaining pH. We talked about the arterial blood gas. We talked about metabolic acidosis and alkalosis. We talked about the job of the kidney, where the kidney is the only one who can balance and maintain HCO3. The lungs cannot do that. So we talked about some of this already. Okay, we talked about hypertension with the aldosterone when we did that section. So let's go over the urinary system. There's a couple more things. There's some things that are just common sense, normal, like when we talk about UTI, you already know this stuff, but I just want to mention the NCLEX stuff from those. So don't mind if you already know some information I'm going to go over. I just know sometimes you forget about them. Okay, there's a couple of vocabulary words that I want to go over with you. So bedwetting is actually called anuresis, so you need to know the medical term for that. So bedwetting, NCLEX question, there is two sections or areas. It could be a primary problem or it could be a secondary problem, okay? So that's what I mean by 2. So primary bedwetting means the child has never had a dry night. They've been having this problem forever. That's a central nervous system, okay, issue. Whereas secondary could be from habit, okay, or bad habits. Secondaries where the child was potty trained and then they start having incontinence. So big difference. We want to ID which one we're dealing with, okay? So if it's secondary, you may need to make sure they don't drink water 2-3 hours prior to bedtime, wake them up in the middle of the night to urinate, and little, you know, measures and modalities like that will change this or fix this. But if it's a neurological, you know, central nervous system problem, they may need pharmacological interventions like DDAVP, desmopressin, your antidiuretics that we talked about earlier. So you have to ID which one you're dealing with this one. Worm's tumor. So Worm's tumor, earlier we talked about pheochromocytoma, which was a tumor in the inside of the adrenal glands that sits on top of the kidneys, where if you palpate this child's abdomen, you release epi and norepinephrine. Now, Worm's tumor is literally inside the kidneys, okay? And we said earlier, pheochromocytoma was not cancerous. Worm's tumor is cancerous. Okay, but they have something in common. Both conditions, you don't ever want to palpate the abdomen, because with pheochromocytoma, you were releasing epi and norepinephrine. With Worm's tumor, you're releasing cancerous cells. So both conditions do not palpate abdomen, but for different reasons, okay? Pheochromocytoma, you're releasing epi and norepi. With Worm's tumor, you're releasing cancerous cells, but both of them do not palpate abdomen. So with the Worm's tumor, as this grows, this tumor grows and grows. Same thing with pheochromocytoma. The child's clothes may not fit them anymore. Their abdominal girth may increase, okay? So you always want to do these things to see the changes that are taking place. The only treatment for this is surgery and chemo treatment and all of that. All right, so a couple other terminologies I need you to be familiar with, okay? They're not heavy stuff, but for example, cryptorchidism is when the testes don't descend in the child. There's an age thing with this one. Cryptorchidism means the testes have not descend. It is perfectly normal until the child is 1 year old. Okay, you know how some things have an age cutoff. Okay, remember with the ear canal, if they're 3 and younger, you want to pull it down and back. Okay, there's an age thing with that one. You know, there's an age thing with cryptorchidism. So cryptorchidism is perfectly normal if the testes of the boys do not descend until their first birthday. So if I give you this question and it's an 8-month-old, we don't care. But if it's a 2-year-old, we care. Okay. And the way we treat this is with hormones, okay? So rarely will there need to be surgery for this one. The physician usually treat those with the HCG hormone, but there are cases where there are surgery, but these are not the most popular questions. All right, there's another one. You know your urethra is supposed to be in the middle. Sometimes the baby boys, they're born with the urethra above or below. Okay, so it could be hypospadia or it could be epispadia. Okay, so epi is the dorsal part of the penile area, and then hypo is the ventral underneath. So abnormal, we fix this with the child's foreskin. Okay, so this child needs to be what we call double diapered. So we don't want stool going into the urethra of this child, especially post-surgery. You want to have a diaper that catches stool and a diaper that catches urine. So we double diaper these children. So again, nothing heavy other than the diaper question. I don't know any question about this one. That's on your real NCLEX. All right, bladder exstrophy. Some children are born with their bladder outside. This child needs to go to surgery. And also some children are born with what we call ambiguous genitalia, boy, girl, girl, boy, or both, okay? So again, not heavy, it's just vocabulary words you need to be familiar with. All right, UTIs. UTIs, you're already familiar with UTIs. I just want to mention a couple of things. So our drug of choice to treat UTI, by the way, is still Bactrim. Okay, that's our golden treatment. But there's a little bit of teaching. Don't forget, with the female urethra, it's a lot shorter than the male, so female are more prone to this. Okay, but don't forget little things. Where's my list? Right here. Little things of like wiping from front to back, wearing cotton underwear, silly little things like that. You want to teach the client, okay, and hydrate, flush the urethra. Okay, so some silly little things with this. There it is. There's the list. Okay, avoid also carbonated drinks. Some of you love these sodas. Okay, not good. Get rid of the caffeine and the alcohol and the teas and hey. All right, so we want to, I always start with the least and then we get worse. So we're going to go over disorders where, and then we're going to go over chronic kidney disease, okay, right, where we'll need dialysis. So there's some conditions that we're going to go over and then we're going to fail the kidney. So here's a beginning problem, glomerulonephritis. So with glomerulonephritis, I talked to you earlier about the filtration with the kidney. So this is a decrease in glomerular filtration. So with glomerulonephritis, because of that itis, that inflammation, it decreases the filtration rate in the kidney. So these clients are going to start to become toxic, okay? Because the kidney's not able to filter and get rid of that excess toxin. Headache, okay, increased blood pressure. You see in this picture, their face gets swollen, okay? They may have a fever, weight gain, it's fluid. Now, when you have them urinate, they have what you call hematuria. There is blood in the urine. That is described as smoky colored or tea colored. Keep that in mind. So some questions, you know, they'll say smoky color. Sometimes you'll see tea colored. Same thing, there's blood in the urine, okay? In addition to decreased urine, oligo, we talked about poly earlier, this is oligo, not enough. And then there's also protein in the urine, okay? So they're lethargic, they're losing their appetite. And in addition to all of that, there's all of that blood in the urine. Very dangerous, especially when you're starting to have protein in the urine too. You know the kidneys are really not working properly. And then you take that blood pressure is high, yeah, you have some issues with the kidneys. So some of the lab tests, one of the lab tests we're going to do is a throat culture. Why? The reason we do a throat culture is because a lot of times this is caused by Streptococcus aureus. So we want to rule that out, okay? As a matter of fact, we're very aggressive whenever a patient has strep to avoid glomerulonephritis, okay? And their diet, you also need to know, okay, nutrition, their diet is gonna be low in sodium, potassium, protein. Why? How are they gonna get rid of it? Kidney's not working 100%. So if you give them all of this, how is it going to come out? What goes in must come out. Okay. And the kidneys can't do that job anymore. So you need to rest the kidneys by decreasing this stuff in their diet. Okay. Now, if this continues, you could end up in chronic nephrosis, okay, nephrotic syndrome, where not just a little bit of protein now, they have massive proteinuria. Hypoalbuminemia, we just talked about the liver with that. Hyperlipidemia and edema, all that excess fluid is accumulating. So this is still being under study. There's a few questions on this one that deals with the findings, okay, with the protein in the urine, with the blood pressure, but nothing major with this one because it's still being studied, which is great because it's good. The more they, the less they know about it, the less they question us about it, which is great, okay? But there is the massive protein with the chronic nephrosis. And that's another thing that shifts your diagnosis too. Because remember with glomerulonephritis, it wasn't massive protein in the urine. But this one, when you have massive protein in the urine, the kidneys really aren't working, okay? So they end up with that anosaka. We talked about anosaka when we did OB. They're swollen everywhere, okay? So the alloguria is still happening. The hematuria is still happening, okay? Plus the massive protein in the urine. The other thing that these guys are at risk of is seizures. So automatically put these clients on seizure precaution, and you know what you need to do to deem somebody on seizure precaution. Okay, so now let's go over kidney stones, okay? And then we'll go into acute kidney failure and chronic kidney failure. So kidney stones are more prone in male. Like earlier I said gallstones were more prone in female. So renal calculi is more prone in male. We have to share the madness, right? So some things are more prevalent in certain culture groups. And so same thing with male and female. So nausea, vomiting, hematuria, blood in the urine. Don't forget certain terms that we use called, remember we described where the pain is, the flank area. So they have that flank pain. So literally if you tap the back of this client, very, very painful for them. So we're gonna do a urinalysis. We're going to do a cystoscope, all of that. X-ray, but priorities to manage that pain, okay? So that pain management is priority with this condition, okay? Depending on if a client is really prone to doing this, physicians are more open to doing lithotripsy with kidney stones versus gallstones, but it can be used for both, okay? So you also remember who's at risk for these. We talked about them, the hyperparathyroids, okay, or hypercalcemic client are more at risk for stones. We talked about that earlier. Okay, so you know the risk factors. High purine diet also puts you at risk because of all that excess uric acid. Okay, so now treatment. So several treatments, we're going to filter the urine and all of that, but don't forget about the lithotripsy I mentioned earlier. This is becoming more and more prevalent on your NCLEX than before. So lithotripsy is the machine on the top right-hand corner. So it's going to send a wave that is going to break these stones. So because remember, the stones, it's like trying to fit a marble through this tiny little hole. It cannot happen, and that causes all that excess pain because we have a lot of pain receptors in those areas. So lithotripsy breaks that up, okay, so that they're tiny and you can pass them without all of that pain. So if their uric acid is high, they may be an allopurinol, okay, like a gout client, okay, because that's going to help prevent calcium and uric acid. Again, pain is priority, so get those opioids to be part of this regimen, okay? Hopefully they don't need a nephrectomy because we don't ever want to remove kidneys, okay? So now acute renal failure. So literally the kidney fails to function. So there's not enough blood flowing through the kidney. So that's a major, major problem. If we don't fix this real quick, they go into full-blown renal failure and they'll need dialysis. If that can happen, death, okay? But acute renal failure has phases, okay? This is where your questions come from. Pay attention what phase you're in. And the way you know what phase you're in, it depends on the urine output. So when you're in the alloguric and uric phase, you're getting less than 500 mLs in 24 hours. Okay, when you're in your diuretic phase, okay, you're getting more than 500 mLs in 24 hours. Okay, so one of the things we want to do one of the management we want to do is preventative. Number one, if you could prevent this, let's do that. So preventive provides a client with education, a lot of teaching, okay? How do you use your medication? How to stay hydrated? How to not get toxic? So preventative measures are great because that's what causes the acute, renal failure. So clients who are, doing polypharmacy and mixing drugs together or poisoning, So all of these things could cause that acute renal failure, but they may need dialysis temporarily. We're going to talk about dialysis, okay? So complication could use to chronic renal failure. So we want to avoid that, okay? So nursing intervention, medication reconciliation will be key for this. Okay, because again, the kidney's failing, the last thing you want to do is stress it with certain medications. So the dose may need to be adjusted. Okay, we want to weigh them, daily, but if they need dialysis, we're going to talk about that. So chronic renal failure, you have a glomerular filtration rate for sure less than 60%. So they're going to have the nocturia, polyuria, headache, increased BUN, increased creatinine, all of that in the excess. So now they need dialysis, right? So when you're in chronic renal failure, okay, or another term for this, end-stage renal failure, same thing, ESRD. So you have where the kidneys filtration percent is very low. You can't remain that way. What comes after this is death, okay? So you're going to need hemodialysis. Okay, so let's talk about hemodialysis. There's quite a few NCLEX questions with that topic, but I want to make sure also utilize this little mnemonic because it helps you to know how the chronic renal failure client presents. There's going to be some neurological effects, okay? Confusion, obviously, because your blood is for the lack of a better word, it's dirty. It needs to be clean. Too much toxins in there, your kidneys cannot get rid of it. That's going to cause some confusion. Okay, your blood pressure is going to go up. You're going to be swollen, okay, pitting edema. You're going to have some shortness of breath, some GI problems, okay. A lot of systems, actually every system is impacted by renal failure. Okay, I have a little chart for you coming up to show you all of the systems that are impacted by renal failure. But yeah, just about every system, your skin, everything is impacted by your kidneys not being able to do their job. Okay, I love this little mnemonic too. There's a couple NCLEX question on here. Let me point this one out since it's right in my face. So hemodialysis, you want to evaluate and assess the site. I'm going to go over Brewitt and Thrill with you in a moment. But you see here where it says do not take blood pressure or obtain blood samples from extremities that have access site. That is an NCLEX question. Okay, you don't want to take the blood pressure and an arm with an AV fistula. My goodness. You don't want to use that for your routine blood draws. My goodness. So you always want to go the opposite. Okay, so that's a silly NCLEX question that's not going to go anywhere. That's not the arm you want to do an arterial blood gas in. Okay, so please don't miss that question. But when you're at chronic renal failure, just like when we talked about with the liver earlier, you have irreversible, okay, damage. Same thing here. With chronic renal failure, this is progressive, irreversible breakdown, deterioration of the renal system. You don't all of a sudden regain, no. So these clients that end up on dialysis for chronic renal failure, this is for life until they die. Okay, so some of the causes are here. Okay, you see diabetes is a nasty little bug. Okay, glomerular filtration. We just talked about glomerular nephritis is another nasty cause. So we want to do that throat swab to make sure, and we're aggressive with these things because we don't want to end up in chronic renal failure. Here's the table I talked about earlier. When you get a chance, go over this to see how every system is impacted by chronic renal failure. Okay. Every system. So now let's talk about dialysis because that's just NCLEX out the wazoo. All right, so for dialysis, they're going to have what we call an AV fistula, okay? So dialysis itself is a substitute for what the kidney should have done, okay? Should have been able to do. So there's a couple of names for it. You also sometimes you see RRT, renal replacement therapy. That is what it's doing, replacing the kidneys. So normally us, a healthy person, no person that doesn't need dialysis, we filter about 120 to 150 quarts of blood each day through our kidneys. That sounds exhausting, right? So if the kidneys are not working correctly, that waste doesn't get filtered, it builds up, okay? And if we don't do the external dialysis, we end up in a coma and death. So dialysis will prevent that waste from accumulating. So we pretty much clean the blood externally. That is what dialysis is doing. Okay, it's going to remove all of those toxins, the drugs, the things that the kidney wasn't able to remove, and have the client urinate it out and be done. So hemodialysis is very time consuming. Okay, it's like a part-time job because it must be done minimum of 3 times a week, and it takes hours, 3 to 4 hours a day, sometimes more. Okay, it depends on the need of the client or if they miss, treatment before, but you cannot miss like 3 dialysis treatment, you'll die. Okay, so very important. And again, yeah, if you have to do something like that, you cannot keep a full-time job because it's time consuming. Okay, it's like a part-time job. So here's a nice picture of an AV fistula. So when we assess the fistula, there are 2 things we're looking for. Okay, we're feeling for the thrill. It rhymes, so you'll never forget it. Feel for the thrill and listen for the bruit. Okay, so feel for the thrill and listen for, and you can't miss it. Like you'll feel it underneath, your fingers. You can't. And then when you listen, it's loud. That means that's a patent, nicely, beautifully working AV fistula. Okay. The other couple more things I want to mention with dialysis. Before dialysis, you must take certain vitals, and the blood pressure is one of those. So if the patient is hypotensive, they give you the vitals within your question, and the client is hypotensive, you will hold the antihypertensives. Why? Because dialysis tends to cause hypotension. So imagine you have a patient right before dialysis who's already hypotensive. You're gonna give the antihypertensive medication and they're gonna go through dialysis. So you have 2 things lowering their blood pressure. They may code on you. So if you have a hypotensive crisis before client before dialysis, hold the antihypertensives. So think about it too. There are some medications you want to give after dialysis, because if you give it before, then you end up maybe even wasting some of those. Like if they're on vitamins and supplements and stuff like that, you don't want to give it right before dialysis. You may end up, depleting them of those vitamins and minerals if you do it right before dialysis. So think about it, look at your vitals so you'll know what you're holding and what you're giving. So now this client may need a kidney transplant. Okay, great. But remember, when you do a kidney transplant, it is not your organ, it is somebody else's organ. It takes time for your body to know that. So one of the things that we must do is deplete your immune system, okay, so that your body doesn't attack this organ, okay? And it takes years for your body to get to know this organ and know, okay, it's part of me now, I won't attack it. So we have to deplete your immune system. And the moment we do that, you're at risk of so much, okay? Don't go next to anyone with a cold, with the flu, with anything, because you cannot handle any type of infection. So you really need to make sure you're taking precaution, or else you end up catching something, you can't fight it, and then you end up, dying from that after a transplant. That's crazy, right? Let's go over prostate disorder now, benign prostate hypertrophy, so the men. So now you see there's a nice picture of the prostate on the top left. With men, sometimes this gets enlarged, okay? Usually men wait very late to do something about this. They usually do something about it when pain comes, or they're dribbling or having hesitancy or incontinence is when they go and check it out, so which makes it very late. But a couple of questions. So as the prostate enlarges, it blocks the urethra, okay? It blocks that passageway for the urine to come through. So as that passageway gets narrow and narrow and narrow, and the person comes in for a checkup, there's a certain way for you to handle this. First thing first, you want to pull your serum prostate specific antigen, or AKA PSA. Your prostate specific antigen serum is blood work. You want to do that before you do a physical exam. And the physical exam is done rectally, like in the picture here. You're gonna glove up. We nurses don't do this. However, we get questioned as if we do, so you do need to know what I'm teaching you, but the physician does this. So glove up, okay, rectally. The physician will feel for any enlargement of the prostate, but that's done rectally. So before you manipulate the prostate, get your PSA serum, okay? So once, the client is diagnosed with enlarged prostate, they need what we call a TURP, transurethral resection of the prostate. So there are some medication we use for the signs and symptoms, okay? Cardura is a great drug, doxorubicin, okay, or terrazosin, Hytren. Proscar is good too, and Proscar is very different. Proscar works on decreasing the size of the prostate, whereas the other medications work on the urgency, the hesitancy the client has, the dribbling, the nocturia that happens at night, the urine that happens at night. But Proscar, okay, finasteride, works on the size. It shrinks the prostate. But eventually they need what we call a TURP, okay, which is transurethral resection of the prostate, where a large bore catheter or needle goes through the urethra and open the passageway. There's questions post a TURP. Okay, post a TURP, there's some teaching, first of all, you should have done pre-op, like letting the client know they're gonna come out with a continuous bladder irrigation bag that is gonna be flushing the urethra, and what comes out may be bloody. There may be some discomfort. The catheter is going to be taped at the side of the thigh. Do not kink, the catheter. Do not flex your hip so you don't kink the catheter. So there's a lot of teaching pre-op. But post-op, you want to make sure this doesn't get obstructed, okay? So quite a few teaching before and after. So let them know you're going to come out with what we call a continuous bladder irrigation bag that's going to be flushing your urethra. It's normal to have clots in there the first day or two, perfectly fine. They may have some spasm, okay? So there may be a little bit of tenderness and pain, but they're going to be, on bed rest for a good 24 hours and give them some pain medication. If they're not NPO for whatever reason, let them drink fluid. We want to flush that urethra naturally as well. Okay, let them know what you see come out at first may be very bloody. Don't freak out. Okay, don't freak out. So now that was the male. Let's do a couple of female things that aren't too, very popular, but just a couple of vocabulary words that I need you to know about. So the female reproductive disorders, one of them is called cystocele. So what cystocele is, post a hysterectomy, some women have a condition where the bladder drops or herniates into the vaginal canal. So that is called cystocele. So the only treatment for that, there's a little device that we use called pessary. Okay, Pessary. So pessary is going to be placed in the vaginal area to keep the uterus off of the bladder. Okay, so that's the job of the pessary. So again, post a hysterectomy, this is very common. Okay, so post a hysterectomy, as you can see in the picture here, the descending, like the falling, okay, of this one organ on top of the other, that's, I mean, if you think about it, gravity is another cause of that. You have one organ that's no longer there, so then you have the herniation of the other. So the pessary just keeps it off of, the vaginal area. And teach them to Kegel, nothing else with this one. PID, okay, so don't mix PID with endometriosis. Let me tell you why. PID is usually from an STI, sexually transmitted infection, okay? Whereas an endometriosis is usually from an overgrowth, okay, tissue growth, okay? So don't mix them, okay? So PID patients with gonorrhea, syphilis, stuff we're going to talk about in a moment, are more prone to pelvic inflammatory disease, okay? Whereas with endometriosis, more of an overgrowth tissue in the uterus, okay? But both of them, signs and symptoms are similar with the fever and the pain, okay? And the inability to keep a pregnancy. They have a lot of miscarriages, these women, okay, with these conditions. And it's very emotional if they do want to have children because they're not able to. Another vocabulary word I need you to be familiar with is called dyspareunia. Right here, it's in red. Dyspareunia is pain during intercourse, okay? So keep that in mind. I don't want you to see that word and then click be like, what the heck is that? Dys means pain, okay? Dyspareunia is pain during sexual intercourse, and that's very common for these individuals, okay? So now let's talk about cervical cancer. You can read, nothing major with those. Let's talk about the STIs. the STIs, the sexually transmitted infections, you do need to know which ones are bacterial, okay, which ones are viral, and which ones are fungal. First of all, the moment you know the cause, you'll know how we're going to treat it. Okay, so the antibacterials are going to be used for the bacterial infections, the antivirals for the virals, and the azoles for the fungals, right? So you also need to know how we diagnose these, not all of them, but some of them are very common where you do need to know how they're diagnosed. And there's little things I'm going to point out with like the non-tender or painless or painful vesicles. So there's little things you need to know about each. I'm going to pull out the NCLEX stuff, okay? And also pregnancy is a big deal with those because how you treat them if the client is pregnant differs than if they're not pregnant, okay? So I'll make sure everybody's good. Reconnect. Okay, you're good. So diagnostic, the zinc smear, that's the zinc smear on the bottom right here, we use for virals, okay? For syphilis, we use the VDRL, okay? For your Shinkreusch stuff, we use the Gram stains. Those are the most popular ones. We're gonna talk about management for each of them. So this is management in general. So we usually try and treat topically and systemically, especially if they have vesicles. We wanna treat both topically and systemically. Okay, so the first one is chlamydia. Chlamydia is the most prevalent one, especially here in this country. Okay, so affects both men and women. So chlamydia will cause the foul-smelling discharge, dysuria, pyuria, with the pus, fever, nausea, and vomiting. So how do we treat chlamydia? Chlamydia is a bacterial infection. So we're gonna use the antibiotics, vibromycin, azithromycin, doxycycline. However, if your client is pregnant, wake up. Because I would not tell you about the pregnancy if you didn't need to process that. So if I tell you it's a pregnant client, wake up. Because you cannot treat them with just anything because they cross the placenta. Your options are less if they're pregnant. So if they're pregnant, erythromycin and amoxicillin, that's it. Those are your drug of choice, okay? So pay attention if your client is pregnant, okay? Because your options are erythromycin or amoxicillin. You cannot give doxy during pregnancy. You cannot give quinolone or tetracycline or none of those, okay? I love the little mnemonics because they're funny, okay? But you see why. Hepatic failure, gray baby syndrome, autotoxicity, teeth discoloration. So pay attention to the little mnemonics, they make sense. And these clients are at risk of PID because I told you, you know, your STIs are the cause of PID. And of course, infertility, they may not be able to carry the child to term. Chlamydia sisters, gonorrhea. Okay, the two sisters. So gonorrhea, you know, these are spread sexually. So let me go NCLEX in general for all of these because they're all sexually transmitted infections. So all of them, your priority is to prevent the spread of. So you get this NCLEX question, it's a funny one too, where the client calls you and they have a history of chlamydia, gonorrhea, and STI, right? And what's the priority teaching? No more sex. There's one answer that says, come to the clinic. That's not your priority answer. You do want them to do that, especially if they're having an outbreak of sores and things like that. You do want them to do that, but tell them not to have sex because they could have sex on the way to the clinic. And then you would not have done your job of preventing the spread of, okay? I know that's like funny. It's like, yeah, but it's true. They could have, yeah. So priority, no more sexual intercourse, please, until we, yeah, educate. Okay, so gonorrhea is the sister, okay? So both in men and women, these are the signs and symptoms. You could go over these later. Treatment. So treatment, again, if they're pregnant, wake up. Okay, a lot of people are allergic to penicillin, so pay attention to that as well. Okay, so your only option in this case, if they're pregnant and allergic to penicillin, would be erythromycin. Okay, some complications that could occur with these, you can check those out later. Trichomona, what I want you to remember about trichomona, it's a fungal, it's flagellated, but the other thing too, the sign and symptoms is slightly different for trichomona. Trichomona is the one with the frowdy yellow-green discharge. Okay, so keep that in mind. And of course, because it's fungal, you know, the azoles are going to be a part of the regimen. Okay, so metronidazole, because it's fungal, the azoles. So we treat both topically and systemically. Okay, herpes is special. Herpes, looking at the time. Herpes, there's two types on your NCLEX. There's herpes simplex virus 1 and there's 2. So herpes simplex virus 1 is what we call above the waist. That's the cold sore. And then herpes simplex virus 2 is the STI, below the waist. So the cold sore, 90 some odd of the population has herpes simplex virus 1. If you've ever had a cold sore, you have herpes simplex virus 1, okay? The first time I had an outbreak of a cold sore, it was so severe. I thought I was having an allergic reaction to something. My face, my mouth literally grew. When was this? I think this was like probably at least 11 years ago, because I think I was pregnant with Gabriel or right before that. So it comes when you're under stress too. And remember, it's one of those that follow the same track. So I get the cold sore whenever I'm overly stressed right here. Never changes, always right there. My sister too, she gets hers right there. And mine usually comes around the holiday. I don't know why, because I don't even feel stressed, but then it comes. So that's herpes simplex virus 1. My 4-year-old gets it too around here. So I have my medicine always ready because we're prone to it. So that's the type 1, not a big deal. The big deal one is type 2. So let's talk about type 2. So herpes simplex virus 1 is the above the waist, the cold sore. Most of us have that. Herpes simplex virus 2 is the below the waist. That's the STI one. So that one has an incubation period of 1 to 45 days. 45 days is a long time, folks. Okay, that's a long time. So now what happened with these, you have the burning, urination, the pain, the fever, especially if you let this, continue, it gets worse and worse. A couple more things I want to tell you about the herpes simplex virus 2 for treatment. We use the claviers because it's viral, right? Okay, so your claviers are gonna come into play for this, but you also wanna teach the client, especially if they have the sores. Good hygiene that's your NCLEX portion. Good hygiene is priority because they want to know that you know what to teach the client. Okay, so good hygiene, fitting underwear, the sitz bath are great, and of course the pain medication, but priority, avoid sexual contact. The lesions, as long as the lesions are present, you are so contagious. So just like chicken pox, they have to dry up, crust stuff, fall off, or else you're contagious. So they're very contagious, so avoid, okay? And the viral family. HPV is not as common on the NCLEX as it used to be. Just remember, those are a group of viruses that cause genital warts. And the big deal with genital warts is you cut this off, it grows back. But we could freeze it, burn it, extract it, but it comes back. But they're not harmful, they're just disgusting. They don't hurt, they're actually painless. Okay, keep that in mind, they're painless. But yeah, they're fleshy and they grow back. They love dark, moist area. So make them uncomfortable, right? Keep the area dry, okay? So make them uncomfortable. So it's good to know what they thrive in, so we don't give them that environment where they're gonna thrive, okay? So they thrive in warm, moist area. So make them uncomfortable, okay? So they don't grow. So there's no cure for them. And again, I told you cut it off, it grows back. So we could do cryotherapy where we freeze it. Okay, some physicians burn them, some physicians cut, whatever. So, but there's no cure, okay? Syphilis is special. There is a select law that apply on syphilis. Syphilis has a primary, secondary, tertiary. So let's talk about that, okay? So, with syphilis, the incubation period 10 to 90 days, again, long time. We hate when they have such a long incubation period. So symptoms of syphilis. So again, syphilis has primary, secondary, tertiary. So how do you know you're in the primary? How do you know you're in the secondary? How do you know you're in the tertiary? And remember, you need to know syphilis really well because of the select law that apply. So you know you're in primary syphilis when you have these painless lesions, okay? You see in my picture here? You have the sores, okay, and they don't hurt. So painless lesions in the genital area, you're in the primary stage of syphilis. You know you're in the secondary stage of syphilis when your organs are now impacted, okay? So it's flowing through your bloodstream and it's going to affect all major organs. That's why they have the alopecia, the malaise, the liver and kidney problem, the skin rash that you see in the picture here, the genital warts, because remember genital warts come from viral infections, okay? So they're at risk of the genital warts we just covered, mucus patches. So you're in your secondary. Your tertiary, the third stage, is a little bit different as well. That one could take from 3 to 15 years to appear. That's crazy, right? So that one, when you start having neurological, cardiovascular, bone issue, you're in your tertiary stage. Okay, everybody's good with that one? You're good? Thumbs up. Select will not apply. Okay, so treatment. Oh, by the way, NCLEX. Whenever a client presents with any STI, you want to do HIV test. Okay, so one more time, any STI, get an HIV test. And you know you need consent. You can't just do it without them knowing, but get the consent. Oh, I think earlier I said viral for syphilis. I'm sorry, I meant bacteria, okay? Couple NCLEX questions. I want to make sure I covered everything. So syphilis, you're good, primary, secondary, tertiary. It's bacteria, by the way, so your antibiotics are going to come into play, not viral. Another NCLEX question is flowing through my mind. Okay, so you know about the pregnancy. I'm not going to mention that anymore. Okay, the HIV, you know, doesn't matter which STI they need, you want to do an HIV, but get the consent.
All right, everyone, we are just about out of time. I want to remind you of a few things. Number one, don't forget to watch the musculoskeletal webinar. It's at the very bottom. Make sure you get that done. After you've completed everything, then you want to go ahead and do your diagnostic test. After you order that, it will come with instructions on what to do. You will get the link, you will get the username and password, and you will get instructions on how to go about taking the diagnostic test. So I will also have a video at the very end of the webinars that walks you through the diagnostic test, the purpose of the diagnostic test. So don't forget to watch that. And lastly, after you've completed all of the webinars and you've done your diagnostic test, schedule a one-on-one with me. Just go back to home on my calendar. You will see my availability. Schedule the one-on-one so that I can go over your diagnostic test with you and show you where you're strong and where you need to continue to work. Okay, so that is extremely important. That is how I'm able to guide you and share with you whether you're ready for the NCLEX exam or not. So recap. Finish musculoskeletal, do your diagnostic test, schedule a one-on-one with me, okay, so that I can tell you whether you're ready for the real exam or what time frame or how long it should take you and what resources you should be using to better prepare yourself. So again, thank you so much for being part of this webinar. Reach out to me if you have any questions or concerns. All right, have a great day. God bless and be safe.